Thank you very much. So welcome to this meeting of the Adults and Wellbeing Scrutiny Committee being held on Monday, 7th of March 2022. My name is Councillor Alyssa Spindlehurst and I'm the chairman of this committee. For those present in the meeting room, if fire alarm sounds, please leave the building by the nearest exit and proceed to the assembly area in the car park. The agenda papers and other relevant information for this meeting are available for public viewing on the Herefordshire Council website. The Council is streaming this meeting live on the Herefordshire Council YouTube channel and is making a recording. To ensure that recording quality is maintained, please speak as clearly as possible and keep background noise to a minimum. Please ensure that mobile phones and other devices are turned to silent. People are permitted to film, photograph and record our meetings, provided it does not disrupt the business of the meeting. We have no members of the public present. Voting will be undertaken by a show of hands in the room. Only committee members present may vote. We have a number of people in attendance as virtual participants. Can I request that they use the raise hand function within the system if they wish to contribute? Thank you. So agenda item number 1, apologies for absence. Have any apologies been notified to the clerk?
Councillor Pauline Crockett, the Cabinet Member for Health and Wellbeing.
Thank you very much. And name substitutes. Have any name substitutes been notified? No, so we still have committee member down because Councillor Sullivan. Okay, thank you. Number 3, declarations of interest. Do any members wish to declare any Schedule 1 or Schedule 2 or other interest in any agenda item? Thank you very much. Number 4, minutes. The minutes of the meeting held on the 10th of January 2022 are included in the agenda at pages for approval. I have an accuracy correction to make, which was the second bullet point on page 11 should read HBOS, is the Herefordshire Voluntary Organisation Support Service, and not HBOS. I move that the minutes subject to the amendment be signed as a correct record. Can we have a show of all in favour? Any against? Any abstentions? Thank you. Agenda item number 5, there have been no questions received from members of the public. And number 6, no questions have been received from councillors. Agenda item number 7, we have been asked to consider whether we should go into private session for the item on Turning Point because of the nature of the appendix. And we've discussed this in a meeting prior to this meeting, and it was felt that we can avoid the need to go into private session by not referring to the statistics because of the nature of the very small numbers of statistics we're talking about that are in the exempt appendix. So if we respond to that item on the agenda in general terms, that would be acceptable. And unless there's disagreement from the committee, we will continue with the meeting in public. And just to add into that, it was also agreed that we will have a briefing as a committee on any details that we want to look into within the next meeting in the future. So all in favour of that? We'll go on. Thank you. Councillor Tillett.
Thank you, Chair. Correct me if my memory is wrong, but also at that pre-scrutiny meeting last week, we were promised a glossary of the endless abbreviations and terms that we use. In fact, I think it was even minuted as an action to be done. If it has been done, I seem to have been missed off the circulation list.
Thank you, Councillor Tillett. I haven't received a glossary either. Mr. Smith, do you have a recollection of that?
It remains outstanding at this point, but any reflections today from councillors we can expand on should we need to do so.
But the whole point of the glossary is so that we could have it before this meeting, so we could understand what it was about, so we could then scrutinise it. There's not much point about it if it's still outstanding. Surely, Chair.
Yes, Mr. Tillett. Sorry, Councillor Tillett. Yes, no, you're right. I think that but we are where we are with it, and we might as well just crack on. But I think actually as a general rule, because often the nature of this area of the council's work is there are a phenomenal number of shorthand abbreviations and acronyms that are used. And for those of you who work in this area, this is familiar to you. For those of us for whom sometimes we're coming at it for the first time, it can be really hard, and you have to kind of sort of almost decode a lot of stuff. So as a general rule, we should just have always glossary of terms, and certainly not use acronyms wherever possible. Councillor Gandy.
Yeah, I mean, I have great sympathy with what Councillor Tillett says, and what might be helpful in future is if a glossary is felt beyond the capacity of the officers, is at least when the report is written, that the first time that acronym turns up, it is put in full, and from then onwards it is known by its initials or whatever. And that would be really helpful, because I think we need to understand that members of the public also look at this, and if we don't understand what the terms are, they're certainly not going to, and they would not have got a copy of the glossary either. So I think if you could at least put for the first time you use it, you put it in full, and then from then on we would know what, and the public would know what we would.
No, it's a good idea. And I think actually, to be fair, Councillor Tillett, I also bear a share of that, because I could have followed up. I didn't. So.
Yeah, but I'm not apportioning.
No.
Well, I'm not apportioning blame to you, Chair. But when we have a meeting a week ago, where a senior officer gives a pledge to provide something, where even asks for it to be minuted as an action, so that we can do our job properly today. A topic that was discussed at length in full council on Friday about the effectiveness of scrutiny, and yet that action isn't followed through. And I'm sorry to Mr. Smith, but to glibly say, oh, well, if there are any outstanding actions, we will carry that. It's not really.
Yeah, for this meeting,
it's a waste of time, you know, and very, very frustrating.
Yes, thank you, Councillor Tillett, and I think that'll be duly recorded and minuted.
There's only to speak there. In fairness to Mr. Smith, he did actually make a note of saying, can that be actioned, and it kind of fell for it. And unfortunately, the democratic officer who was in that particular team has moved on, and it's kind of fallen through the gaps, unfortunately. So, to be fair to Mr. Smith, he did actually raise that to be actioned. So there is a degree of, in terms of, it should be raised.
Chair, that's very gracious of the governance team, but I will take full accountability. I lead on the Community Wellbeing Director. It's my responsibility to ensure that actions complete, so I'll take that away.
Thank you, Mr. Smith. Thank you, Councillor Tillett. Okay, so agenda item number 8, substance use services in Herefordshire. So I welcome staff from Turning Point who are here to give us an overview of substance use services in Herefordshire, and specifically their work since taking over as the new provider. I'm welcoming Chris Fax, who's Operations Manager in Herefordshire, Kevin McNamara, Senior Quality Assurance Advisor, and we also have Kate Thompson-Dixon, Senior Commissioning Manager, and Rebecca Howell-Jones, Interim Director of Public Health, to answer any questions. So I'll pass over to Turning Point team, whoever's making that, if they want to make a presentation.
Hi, good afternoon. Can everyone hear me okay?
Would it be possible to shut down the participant list so that you're a bit bigger? Thank you very much.
That's better, thank you.
Or maybe even go on to speaker mode for this particular bit. Thank you. Oh, that's brilliant.
Wow. Wow, okay, thank you. Hi, hello everybody. Apologies, I was a couple of minutes late. I was having a few issues with the Zoom link, but thank you for sending that through to me, and glad I managed to get on board. Yeah, thank you. As you said, I'm Chris Franks. I'm the Operations Manager for Turning Point, covering the County of Herefordshire. And apologies, this is my first scrutiny meeting, so if there's anything further I need to provide or tell you, please let me know. I have sent a report previously, which I will review and summarise. I believe I've got about 15-20 minutes of time available on the agenda, so I will just try and summarise some of the key points. Happy then to answer any questions that anybody may have about the report or anything else that I've mentioned. So what I'll do just initially is give a very quick introduction about Turning Point, just for anyone who isn't familiar particularly. So Turning Point is a national social enterprise. You'll see this at the top of the report if you have a copy of that there. And we provide health and social care services in around 300 locations across England. So Turning Point was commissioned to deliver an integrated drug and alcohol recovery service for Herefordshire on the 1st of April 2021. And we provide a holistic treatment model to meet the needs of service users, including young people service for those aged 11 to 24 and an adult service for those aged 25 and over. As you'll see, if you have the report in front of you, I have provided a number of graphics and infographics to try and make the sort of information a bit easier to access and hopefully a bit clearer. We use an evidence-based approach to support people, and we offer a comprehensive assessment and risk management planning process to provide access to a range of treatment services. And you'll see if you've got access to that now, the referral pathway moves into a number of different treatment pathways, including reclaim, resolutions, managing alcohol pathway, building recoveries, and then a separate pathway around any high risk or highly complex individuals. The idea of the service is it's providing evidence-based treatment to help move people from the point of referral and assessment through their treatment journey and into long-term recovery. There's also an aftercare package, which I will talk about slightly later towards the end of the session, as it's one of our areas of development that we're looking to enhance and improve. Within that, we have allocated recovery workers for every individual accessing the service. So caseloads for recovery workers vary from approximately 45 up to about 60, 65 at the moment. There is currently one member of staff vacant within our opiate team, so that will lower the overall caseload down probably to about 55 in total, which is, as a sort of national level, is actually quite a low caseload for individuals to work with, which means that the interventions being offered are able to be far more tailored to individuals and are far more effective for our engagement with those individuals. So we're in quite a lucky position, quite a fortunate position with how we're managing that within Herefordshire, that everyone then gets that structured intervention, that structured support, is able to then have their allocated worker work with them on a much more personalised basis. Throughout the journey, I have included a staffing structure. I won't go into lots of detail about that, but there is an overall management team within the service, and each of those managers oversee a particular aspect of the treatment delivery. So we have a clinical lead who oversees our clinical services manager and non-medical prescribers. We also have a team leader overseeing our partnerships approach, and that includes our criminal justice and outreach provision, as well as our young people service provision. And then we have another team leader covering our alcohol provision and another team leader covering our opiate provision. And again, that's just ensuring then that we have streamlined and focused management and support of those different pathways. Our team leader around alcohol also focuses on our group programs, which I can talk about slightly more in a second, and also our safeguarding approach. And then she's our safeguarding lead for the service. And then we have an admin team that's also overseen by data analysts, providing a lot of the data that I've provided into the report for you today as well. Within that team, we've also got senior assistant psychologists, additional admin staff, and we also have students and volunteer placements, again, which is another development area that we are exploring as part of the new provision of the service. One of the key things to mention about the delivery of our service, and again, you'll see it on the staffing structure on the report, is that we also have a representative from Healthwatch in Herefordshire. So we work in partnership with Healthwatch to provide focused interventions and focused support from our service users, provide feedback and opportunities to really hear the voice of people that access treatment, so that, again, what we're delivering is meeting their needs and is supporting the current requirements of our population. So Healthwatch have provided a representative who is co-located with our service. Again, the pandemic has obviously had an impact on this, so a lot of the work has been via telephone or video calls. But as we start to move out of the pandemic and away from those restrictions, we're going to be hosting more on-site face-to-face appointments and contacts. And that will include also a monthly feedback forum, which will be overseen by the Healthwatch representative. And it's an opportunity then for service users to come and tell us what they're enjoying about the service, what they're finding might be a barrier to them accessing treatment, and what we can do to improve access and the support that we're offering. So Healthwatch is quite a significant partner for us within that partnership, within that work. And we're quite looking forward to working with them in more detail. As I've mentioned, the pandemic, we are offering a hybrid model in terms of our treatment delivery. So we have continued to work throughout the pandemic. The service didn't shut down or stop, as people can appreciate. The sort of work and the support we're offering can't suddenly take that away. It needs to be in place. So we've adapted what we've offered in terms of face-to-face and remote sessions, primarily limiting our contact to remote and video calls, but being able to offer face-to-face interventions for people that were particularly at risk or would struggle otherwise to access support and services. So we've maintained satellite clinics across Ross, Leominster, Bromyard and Ledbury. And we're very fortunate to work with some of the hospitals around Bromyard and Ledbury, particularly, and recently with Ross Hospital as well, who have very kindly hosted us to make some of that interventions much easier, much simpler for us to use. And we're very fortunate in Leominster that we're using a space that was historically used by the service in the Bridge Street Halo Leisure Centre. And that gives us a dedicated space that's got ease of access and a great resource for us to offer support for Leominster as well. Again, I've mentioned on the report regarding our central risk and assurance team. So Kevin is here representing that part of the part of the organisation, and really that oversees the driving of the quality agenda across the organisation, which looks at our clinical governance, risk management, complaints, claims handling, the development of our policies and reviews of procedures. And it also looks at the implementation of the quality framework that we're offering and internal quality assessment tool, or the IQOT, that we use to, again, self-regulate the activities that we're offering, ensuring that that's meeting the highest standards of quality possible, and looking really then to improve what we're offering based on those reports. I'm aware that with the report, because of some of the numbers in the data that I've presented, some of the numbers could potentially be identifiable. So I'm not going to run through in detail the performance overview. That information is available on the reports, but what you'll see from that report is that the performance has continued to increase since the first quarter when we took over the service. I'm actually quite proud to say as well that we've just recently confirmed we've moved into the third quartile for performance for our alcohol and non-opiate cohort and our opiate cohort as well. So that's a significant improvement within that first year to see that move into that cohort. And what we're seeing as well with the other two cohorts is that we're on target to move out of the fourth quartile, bottom quartile. And that's demonstrating some of the hard work that's gone in from the team. I won't take all the credit. I only joined in August, so the service had been up and running for a while before I got there. So I won't take all the credit with that one. But the team have worked really, really hard, and the organisation has really supported that to understand the importance of accurately recording the data that we're doing, but also recognising the effectiveness of the work that we're offering to help individuals achieve their outcomes. And that's been a kind of key focus with our performance, is understanding what service users need and want from us, being able to offer that as adaptively as possible so that people get the most out of the treatment that they're engaging with. I don't know if anyone would like me to run through in any specific detail around any of the performance figures. I appreciate there'll be questions at the end, but if there's anything you wanted me to specifically touch on regarding the performance part of the report.
I think we'll let that come out in questions if that's all right. Thank you.
Absolutely. Yeah, no worries. Don't want to skip over it just in case. So as you say, you'll see the infographics on there. These are taken from the latest data at the time of the report, which was November. So they're not currently showing the opiate successes into quartile 3, but the most recent data that we have now seen does show us that we're in that quarter 3 target. So you'll see the projections and the trajectories are on track. And say with 2 of out of the 4 of those now, we're out of the bottom quartile, which again, very excited about. So just to summarise some of the key achievements that we've identified really since taking on the service on the 1st of April, our partnership links with stakeholders has gone from strength to strength. And what we're especially proud of is the work we've done with the local mental health services, the pathways that we have in place to support people from a dual diagnosis point of view. So those experiencing mental health issues and substance misuse obviously creates a highly complex set of circumstances, and the mental health team have worked really well with us to support that pathway. We have a fortnightly multidisciplinary team that takes place where we can discuss individual cases. We can ensure people then are linked into the right treatment pathways. We also have a referral pathway in place to make sure that people can access mental health treatment while engaged with our service in a much more robust and speedy way. And in addition to that, we're also supporting each other with practitioner training. So we're learning more about mental health pathways, mental health provision, and we're helping support mental health practitioners to understand more about substance misuse and some of the tools and techniques to help engage with that audience. Alongside that, we've also developed our partnerships with probation and working with a senior probation officer in Herefordshire Probation. We have a dedicated pathway for criminal justice clients that allows us to offer assessments for suitability for community treatment that can then inform the recommendations by the probation officer. And anyone who is on either an alcohol treatment requirement or drug rehabilitation requirement order receives then targeted support in line with those order requirements. And again, that engagement is reported back to probation to help support the license conditions, sentencing arrangements, and ultimately address people's risk of reoffending. I've already mentioned about the performance outcomes since go live and the significant improvements that have been made there. But what I've actually recently added in is I added a few quotes or a few comments from some of our service users, because beyond the numbers in terms of our performance and our outcomes, what our service users say is incredibly important and valuable to us as well, and actually gives us better indication sometimes of the difference that's being made for them. So just to say, because these aren't in the reports, but I'm more than happy to share the updated version after this meeting. So one of our service users, I've just used initials in here to anonymise. So S commented, the support received from staff at Turning Point had enabled them to take control of their life, stop relying on drugs or medication. They've managed to maintain full-time employment, take better care of themselves, and start a relationship with somebody. S thanked everyone at the service for their dedication and stated they were grateful for the continued support. And M said, I'm very appreciative for all the help and support Turning Point have provided me, and a special mention to the groupies, Michelle, Natalie, Els, Chianti, and Alice. I really wouldn't have been able to do this without you. I found group such an eye-opener. I heard how it was affecting other members, which gave me the boost and motivation to reduce and become abstinent. So for us, it's really important to hear that. And again, that's the work that Healthwatch are helping us, is to really understand the impact it has on the individual beyond there being a number on the form. We have struggled with recruitment, or it's been a challenge, I should say. Recruitment has been a challenge, which has been actually the picture nationally for most health and social care providers. Most services across the country have really struggled. And what we're quite happy about now is that we've recruited several new staff into the service that are really going to help bring new perspective, new ways of working, new ideas into what we're doing. And that includes a new volunteer and peer mentor team leader. This is a new role for Herefordshire. It's not existed previously. And it's something that's going to bring in and really help us develop that recovery offer that we'll be providing to our service users. And again, I'll mention that just in a second. We have new admin workers. We have a new group facilitator who'll be starting in April. We've brought in a new young persons and young adults transition worker and a new safeguarding lead. So all of these new members of staff coming in are going to really help strengthen the work that we're offering as a service provider. And additionally, what we're quite excited about is we've established links with HMP Prescott, which is an open prison just over the border. They run a program called Chase, which is a phenomenal program helping train and accredit people to learn the skills necessary to move into this kind of work, to move into health and social care. And they cover a number of topics that really look at the knowledge and practical skills needed to support either a placement on a voluntary basis or employment into our services. We have three new members of staff pending clearance through that process who will be coming in to offer their unique insight into how we can work with people from a criminal justice point of view and how they can really share that experience that they've lived to help encourage other people to understand the benefits of treatment and to give something back from their experiences as well. Fortunately, this has been allowed through the universal funding that we've received, and it means we've got an extra resource really to support engagement, provide better treatment outcomes for people in the criminal justice pathway, reduce risks of harm from drug-related death, and offer more of an outreach and assertive approach to engaging with people that may otherwise struggle to work with us. And again, having that perspective of somebody who has lived that experience themselves is going to be hugely beneficial. So just the last few things from me in terms of the report, our plans for the future, really. So a key thing, as I mentioned, we've introduced a new young persons and young adult transition worker. So as part of that, we're reviewing the young people service provision. The plan is to create our own brand identity, a brand new approach to how we work with young people, creating a dedicated space for young people to access, to explore their emotional well-being. That will include the work we do with our young adults as well, and aiming to prevent young adults moving into the mainstream adult service as much as we possibly can, and providing those interventions to prevent any further issues around drug or alcohol use developing. We're also going to be exploring greater awareness of the treatment options for young people. We're going to be doing that through promotions in schools, in youth centres and youth clubs, offering a really simple and fast referral and assessment process, offering those interventions at the point where somebody needs it, trying to offer as much preventative information and preventative interventions to stop somebody moving into treatment or requiring treatment down the line. We're also going to be using our social media as part of that to help further increase awareness and make sure we're promoting harm reduction messages to that young audience, and how we can support them to make safe decisions in their life. We're also purchasing a mobile outreach vehicle. The MOV is designed really to help us reach a much more rural audience. So we know obviously with the scope of Herefordshire, it's difficult to request everybody come to us into one place. We want an everywhere, an out everywhere model. So this will allow us to really deliver harm reduction advice, provide needle exchange to areas where maybe people wouldn't be able to access this before, which puts them at further risk of bloodborne viruses. Provide naloxone, which is a life-saving medication that reverses the effects of an opiate overdose, again helping to stop the risk of people dying unnecessarily from drug-related issues. And also again support our outreach to other service users that, as I say, might not otherwise be able to come into the service or feel that they're lacking the ability to travel into different hubs and satellites that we have. What we'll also be able to do is use this to support, for example, with delivering medication for people that might be isolating if there were to be another flare-up of the pandemic or something similar, people who are unable otherwise to access local pharmacies and have no other support network around them that can help maintain and engage them into treatment. So it will really give us a scope to bring that treatment and that support to other people. And as I mentioned earlier on, we've got a new safeguarding lead, and part of that commitment is to work with the multi-agency safeguarding hub or the MASH team to really look at how we can co-locate, improve the effective communication with them, make sure we're sharing relevant information about children and young people to protect them where we can, and provide opportunities for professionals to help develop their understanding to identify substance misuse risk and offer brief interventions that might support engagement and again ultimately reduce harm. And as part of that, we host student social work placements within our service as well, who bring a unique insight, again, helps to support their effective learning, and gives us a great opportunity to enhance the experience and understanding of new social workers moving into this field. And then really the final point I've got from the report is our primary aim for the next financial year is to develop our peer-led aftercare provisions. As I mentioned, part of our treatment pathway is to support people at the other end when they've been doing that work to achieve abstinence or the change that they desire to achieve. We want to make sure there's an aftercare provision, an aftercare support there for them that really embeds recovery and helps maintain that change for them. So our new volunteer and peer mentor team leader is going to be focusing on the recruitment and training and induction of peer mentors, so people with lived experience of substance use, and they will be delivering peer-led interventions to support those recovery journeys, using skills learned via smart recovery training and also Turning Point's own accredited peer mentor program. And I'm very excited. We're just about to welcome our first round of volunteers who've just completed that training earlier this month, and will be starting with us just next week. And again, it's a huge step in the right direction for us to bring those people in with that experience to really enhance the opportunity to work with our service users and people that want to give their time back and commitment to working with people. That's kind of it from the report. So I'm more than happy to answer any questions or elaborate any further.
Thank you very much, Mr. Franks, and congratulations on the improved performance over what was actually a relatively short span of time. It's great to see that it was going in the right direction. I was interested in the pathways referring to community-based aftercare, and would be interested in unpacking that a little bit as to what exactly does that mean and where does that sit. And do you work with, for instance, AA, NA, existing groups, the street pastors, things like this? And is there perhaps opportunity for increased community-based care and indeed prevention? So we're looking at aftercare, and it seems to me there's a lot of working on the problem once the problem has become more acute. But particularly with drinking, it seems to me that there's a there can be cultural areas where drinking is seen as being acceptable and good and fun, and all go out and getting sloshed, and but prevention and information in the community, and maybe, as you say, schools and youth centres and where young people are, colleges and so on and so forth, would be of enormous benefit. So there's two areas there. One is prevention, the other is community-based aftercare. Thank you.
Yeah, absolutely. I mean, the sort of the prevention, the awareness side of things, we've done some work recently. So our new clinical lead, Dr. Morgan Tureen, has done some work with local GPs to really look at enhancing and understanding that awareness of brief interventions and how to have those conversations with individuals where maybe they're not yet seeing that their alcohol use is causing them a dependency issue or a problem that requires them to access a mainstream service, but it's beginning to become more problematic for them, or running the risk that that's where they could end up next. So being able to have those conversations about structured brief intervention to really understand the impact, the risk, and what support is available out there, that's a piece of work that we've definitely been picking up already with the GPs. The feedback has been really, really positive. That work will continue, and hopefully we'll continue to develop that and enhance that. And again, some of that work is linked over to probation and to social services as well, just to really make sure that a wraparound group of professionals understand how to support individuals with that. In terms of the aftercare offer, absolutely. I mean, that really is a key area for us to focus and to develop on. So what we currently offer is a mindfulness-based relapse prevention program. So this is a structured treatment program that supports individuals to really understand some of the reasons why they may be triggered to use substances again, some of the skills and techniques that they can employ to prevent that risk. And what we want to do is build alongside that the recovery community. So you mentioned AA and NA, those mutual aid interventions, for example. So we do have links with those. Again, we're looking to develop and strengthen those links now that the pandemic's ended and we're able to bring more face-to-face activity back on as well. That's going to make things significantly easier for us. And as I mentioned, Smart Recovery is a version of that. So Smart Recovery is a cognitive behavioural therapy-based peer-led intervention, and that's something that our volunteers and peer mentors will be trained to deliver, to offer that peer-led intervention, so that people have got the opportunity to choose the right treatment for them and the right pathway. Some people struggle with mutual aid or 12-step fellowship approach. Other people obviously find it incredibly beneficial. So it's providing that choice for people to access, and that will be a key part of our aftercare community.
Thank you. Councillor Summers?
Thank you, Chair. A couple of questions. How are you coming up with your performance figures? Number one, you can answer these after. Where are your premises located in Hereford? Who are your mental health partners? Because mental health now is a really big thing of substance abuse. I'd say about 50%. And how much has already been started with the schools that you mentioned that you're starting with the schools that we've not already started since April? So if you could answer any of those questions for me, I'd appreciate it. Thank you.
I missed the first question. You wouldn't mind just repeating that? Sorry, it cut out slightly.
Where are you getting your performance figures? How are you coming up with them?
Right, thank you. So our performance is taken from our data analyst, who I mentioned earlier on, provides an overview of our data performance. This is all reported through our national data system. So we use an on-site case management system that allows us to record the interventions that we're offering and the information that we provide, and then that is reported through onto a national level, which provides the NDTMS sort of snapshot of data, which, as I was mentioning earlier on, at the moment is, at the time this report was dated till November. There's always a slight delay and gap in the data, so we're able to then provide more local data based on the case management system that we use, which records all those successful outcomes and performances.
So basically what you're saying is that those figures are coming international from national, not from Hereford.
No, can I just jump in there, Chris, just to give some context with this question? So Councillor Summers, Turning Point and all other drug services across the country have to report their local data onto a national drug treatment monitoring system, which is the system Chris mentioned is called NDTMS, and that is fed through to Public Health England. So the information is available locally via Turning Point, and that is how they put together their quarterly monitoring reports for us. But we also have reports that are published by Public Health England, and that's where we're able to see the comparison between how Herefordshire is performing against those other areas that are most closely statistically similar to them. So it's kind of a two-pronged approach. We have local data and we have the data that's compiled by Public Health England against their measures for successful treatment outcomes.
Thanks, Kate.
Thank you.
I believe the second question was our links with mental health.
No, where are your premises located?
Oh, premises.
In Hereford?
Okay, yep. So our Hereford office is Office Street. So just around the corner from St Peter's Square. And again, apologies, I'm relatively new to the area, so I physically moved here in October. If I get a name wrong, Kevin or Kate will come in and correct me. But it's you say Office Street is our main Hereford site, our main kind of office space. Leominster, as I've talked about, we are located in the Halo Bridge Street Leisure Centre. We're also currently working through Ross Community Hospital and St Mary's Church Hall in Ross. And we're based in Bromyard and Ledbury Community Hospitals as well.
So if I needed your help in Hereford, I could go to Offa Street and be pretty well sure of me of talking to someone there?
Yeah, so anyone who's located within Hereford would have the ability to either access remote or face-to-face interventions through Office Street, which is the central hub. Our referral system is done as an online referral in the first instance, so we encourage people to either self-refer or be referred by their agencies through that. What we're now doing is offering a telephone initial assessment. We found one of the benefits, I suppose, of living through the pandemic is we found some of these hybrid ways of working that have actually helped support people to engage far more. So by offering a telephone assessment, it breaks down some of the barrier that people might have with coming to a treatment service. It could be incredibly nerve-wracking, incredibly intimidating to access services and support. So we want to make that as easy for people as possible. Being able to be at home, being able to be in a comfortable space, not having to feel like you're being quizzed and grilled in a central location can make it a lot easier for people to engage. But we do offer face-to-face assessments if that's deemed suitable for the individual, if that's something that they would want to access. But anyone who comes through into Hereford will be able to access the services through Office Street. I think the next point then was the mental health services, and the fourth point was the young people's provision of the school. So I can respond back to those. So with our mental health pathway, as I said, we've established very strong links with Wyvanny Trust mental health teams. We've also got healthy living trainers coming into the service now to provide more robust support to individuals. And again, forgive me if I get the name, healthy minds, I think is the other phrase that we use within the area, is the other referral route that we link into. I hope that clarifies.
Just back to the mental health, because it is a big concern. Do the mental health partners in Herefordshire have your details, all of them, or is it just the ones you mentioned? So you've got Mind, and you've got a couple of others. You've got, there's something called House. There's a few that should have a link to you. So I'm just wondering if they have it.
I would hope they do. So we have our partnerships team leader who has been very, very well established. He's been part of the service prior to Turning Point taking over the contract, so has a lot of local links as well. And we've been part of various projects. So Project Brave, for example, we link in through, work quite closely with the police around complex and vulnerable clients. So I would like to hope that we are well known as a provider with those services as well, but we're always looking to develop those links further. Myself and Rob, the partnership manager, attend quite regularly these kind of forums and partnerships to explore what we do and really look at the promotion of the service. But Mind, we've certainly worked with, Healthy Living, we've certainly worked with.
Thanks, Chris. I think it's probably just pertinent to say that when the service launched in April last year, quite a lot of communications were sent out across the county, and there was a lot of engagement with partner agencies around the new service. And as Chris mentions in his report, Turning Point actually have the Mental Health Trust in their team meetings each week. So there's a lot of joint work that's taking place. The vast majority of the service users that Turning Point and the Mental Health Trust are working with do have some dual diagnosis, and so the Trust and Turning Point work collaboratively to complete joint care assessment, joint recovery plans and assessments to make sure that that work is as joined up as possible. But Councillor Summers, as you say, it is an area of deep concern for both agencies, and it's very, very complex. So it requires a constant eye on the detail of it, really. And Turning Point are doing a really fantastic job at keeping up those open lines of communication with partner agencies.
And I will just add, having worked with another treatment provider for a number of years in a different area, the partnership and the work that we have in Herefordshire is almost unique. I mean, the level of co-location, the level of partnership working is incredible, and is something that a lot of other services generally do struggle to develop and maintain. So we are in an incredibly fortunate position, and we're very grateful for that partnership work with the mental health services. And as I say, we do plan to continue developing that much further where we can. Just to your final point regarding schools. So yes, we have already been offering interventions within schools. I'm afraid I won't be able to tell you which schools. I don't have that, because that's another manager has done that, just to preempt if that question comes. But I do know we have been in touch with schools. We've actually received some very positive feedback from some of the schools as well regarding the workshops and interventions that we've delivered. That was a previous worker who's now left. And as I say, we've got a new young adult transition worker coming in, and they will be picking up that momentum with the schools again to really develop those pathways. But there has been some real success with some of the schools already.
And sorry, Chris, just to jump on the back of what you're saying there with schools, the last 2 years has been incredibly difficult in terms of working with schools and having access into buildings, in all the usual ways that we would expect the service to work with education settings. There's been obvious challenges presented by the COVID-19 pandemic. So some of that work has not taken off as quickly as we would like it to, but as Chris has said there, that is an area of real focus going forward. And of course, the situation has improved, and so it is now possible to go back to those education settings.
Thank you very much. Councillor Gandy.
Thank you, Chair. I was interested to read about your plans to purchase the mobile outreach vehicle, and I just wondered how close we were to actually having one. As someone that represents a very rural community where there is little or no public transport, getting into Leominster for some people would be impossible. So could you perhaps give me a bit more information on that? Thank you.
Yes, absolutely. So we've identified, so we're actually purchasing an old ambulance, so a previous ambulance, because the layout of the vehicle, the setup of it works very well. Obviously, we'd have to rebrand it to make it not stand out like an emergency service vehicle, because we don't want to get putting the wrong message across. But we've managed to find a vehicle. It's kind of at the stage of really purchasing it, and then finding a local mechanic that will be able to help us to maintain it and to get everything ready on the inside. So we're hoping within the next couple of months to have that up and available and usable within the county.
Thank you. That's again, I'm also a rural ward member, so that's good to hear. I think it would be really useful to have the ability to go out into rural areas. Thank you. Any other committee member got any other questions or comments that they would like to make at this time? It's Councillor Marsh.
Just to reflect that it does seem that you inherited a poor performance where we were in the bottom quartile for everything. And I'm just wondering, looking ahead to the duration of the contract, whether you feel, and indeed the size of the contract, what you feel may be realistic expectations. I mean, is 3 a top, or do you feel we might inch into 2 over, as I said, the length of the contract?
I'm ambitious. I want to be in the top quartile for everything. So I've come from being in the top quartile in previous services. So for me, that's the ambition to work towards. As I say, 2 out of 4 were already in the third quartile. The other 2, it's completely achievable for us to be within that within the next year. I would expect in the next couple of years to very easily be heading towards the first and top quartile.
Great news.
Good, thank you. Thank you very much for your time this afternoon. So do we have any recommendations bring forward other than the recommendation to note?
I'd like the addresses, etc., phone numbers. I know we have one phone number here, but the ones linked to Hereford, like the address of the address for Leinster, all those, and that we need a copy of them. That's basically.
Okay, just to note to the committee.
Yeah.
Okay.
Well, then we can pass it on to our parish councils, etc. If we have that information, then we can pass it on. If we don't, we can't. So,
Okay.
thank you.
Yeah, that's fine. So, yeah, that's possible. Just have all the addresses circulated to members of the committee so they can pass them on through their own networks.
Could we possibly add to that if you yourselves have a regular website or Facebook that we might have that as well? Because obviously that will have greater information we can pass on.
Yeah, Turning Point have got a really good website. If you haven't had a chance to look at it yet, councillors, I would really encourage you to take a look, because it has got all the pertinent information about locations, how to refer, what's available, and lots of other useful advice and information on there as well. So that's really worthwhile looking at, and we can forward, of course, details about how to access the website and also the social media channels. But Turning Point have got a really active presence on Facebook, Twitter and Instagram as well.
Thank you. So apart from that, just a bit of comms. Yeah,
Just to clarify on that one, so addresses of gender points and details of their social media presence. Okay. Did you want anything to do with prevention, potentially, focus on that?
No, I think we'll leave that for, because we've got the second briefing coming up, so we do it as a result of that when it's
Just to the chair, when we get to referrals, there's self-referrals and there's referrals from GP practices, etc. If, to me, referrals means you have to go through someone else, but this self-referrals is, I think we need to put accent the self part. So anybody who's suffering can self-refer themselves. They don't have to go through something else. I'm not sure what you can do about that, but that's just a thought.
I think the thing to do would be to look at what's already in place on their website and so forth, and then if you have concerns with that one, because we have got the benefit of a second briefing on this, that we'll come back and cover that then. Is that okay?
Yeah. And more than 50% of referrals are self-referral. So the vast majority of referrals are made by the person themselves, and in some instances they're from other professional agencies.
Yeah, that's really interesting. Good to know. Okay, so
yeah, that's it.
So we've got a recommendation to note the report and recommendation over that we are given the addresses and information about websites and so forth.
If it helps, I have put our website address in the chat and also our Twitter handle, so it should be easy to take.
Okay, that's great. So can I have a proposer and second of the recommendations? The Councillor Summers, Councillor Gandy. Do you have any comments? Well, we don't have a cabinet member here, but any further comments from anyone? No? Okay. So can we have a vote? All those in favour? Any against? Any abstentions? All in favour. Thank you, and thanks again for your time this afternoon.
Thank you very much.
Thank you.
Thank you. Thanks. So we'll move on to agenda item number 9, which is GP access. And for this item, I would like to welcome to the meeting Charmaine Hawker, who's Hereford and Worcester CCG Associate Director of Primary Care, Dr. Mike Hearn, Managing Director of Taurus Healthcare Limited, Jonathan Leach, OBE NHS England Medical Director for COVID-19 Immunisation, NHS England Associate Medical Director for Armed Forces and Veterans Health, and General Practitioner, Davenhall House Surgery, Bromsgrove. That's a mouthful. Thank you. So this has come strictly because of those reported public concerns over GP access during and post COVID. So that's why we're here, and I invite those people present to make their report to the committee. Thank you.
Thank you very much. and thank you for inviting us along today to discuss with you access to primary medical care in Herefordshire. I'm Charmaine Hawker from...
Could you put the mic a little bit nearer?
Certainly. I'm Charmaine Hawker from the CCG, and I'm the Associate Director of Primary Care. And I'm joined today by my two GP colleagues. We don't intend to go through the report in detail. I'm taking it that you've read the report. But actually, I do know that each and every one of you sat in this room today will have your own lived experience of general practice, either yourself or via your friends and family. What we can't do today is address any individual specific patient queries, but I will give you an undertaking to pick that up outside of the meeting if you would like to do so. I mean, basically, access to general medical services has changed quite significantly throughout the pandemic. There's been a greater transformation in primary care over the last 18 months than we could ever have wished to achieve in the next 5 years had we put a planned programme in place. Now, that's largely as a result of technology. There has been a significant investment in technology infrastructure, and also in terms of primary care GP practices working at scale within their primary care networks. And that very much offers them some greater resilience and longer-term sustainability. NHS England published the latest directive for primary care mid-January. And at that point, they again mandated primary care to operate in a COVID-secure environment. Now, for general practice, that means social distancing, mask wearing in a healthcare setting. Equally, we know that the mandate was again to offer a blend of both face-to-face and virtual appointments. Face-to-face when clinically appropriate, but also a range of video and online consultations. And indeed, they have contracted general practice to provide that level of access to primary care, so they have to do that. I mean, sitting alongside that operating model in terms of how general practice operates, there are a number of significantly competing priorities. Firstly, we've got the pent-up demand that has been that's come about as a result of COVID. So primary care is actually dealing with the backlog of primary medical services alongside meeting on-the-day demand. In addition to that, largely primary care has delivered the biggest COVID vaccination programme ever to be delivered, alongside, again, the influenza vaccination campaign. And equally, we know that there is backlog in secondary care. And actually, those patients then have to be managed in primary care until their secondary care needs are actually addressed. In the report, we talk about GP appointment data. So GP appointment data is published by NHS Digital on a monthly basis. We then get that information from NHS England, and it's at a Herefordshire and Worcestershire level. We don't get individual practice level data routinely. But actually, you will see from the report the latest information in there for December. So that was at a time when we were delivering the COVID booster programme throughout December. General practice was operating 10% above pre-pandemic levels. So the activity was 10% more than before the pandemic. If we include the COVID vaccinations, that's 43% above pre-pandemic. So you can see increasing demand constantly for primary care. 57% of those appointments were face-to-face. And we know that actually that is an area where we benchmark slightly lower than the national. We're generally between 2 and 5% lower than the national average here. However, when you look at the ratio of appointments that are available to our patients, they are greater. On average, 0.29 appointments are available to our patients per head of population compared to the national 0.26. So whilst we are lower, we actually offer more appointments than our counterparts. 56% of our patients are seen within 1 day. Now that was 50% pre-pandemic. So again, a significant increase in terms of the turnaround of when you get to see a GP. and 53% of those appointments were with a GP. Again, we are above the national average where 50% of patients are seen by a GP. Although we benchmark very well, we know actually that there is unwarranted variation across individual practices, and actually we need to know about that. We're always keen to hear in terms of the patient feedback, and we work very closely with Healthwatch. We also have done a number of audits of general practice locally in terms of looking at the National Patients Association report. We've worked with Healthwatch and indeed the National Patient Survey. As a result of that, we've then undertaken individual audits at all our practices across Herefordshire and Worcestershire. And that's really looking at the consistency of messages on websites. Are they promoting they're open to general practice? How easy is it for patients to navigate that information? We've also looked at telephone audits in terms of how long does it take to get through to the telephone? There was a significant range there, and the range was anything between 3 minutes and 25 minutes. Now, where we've seen 25-minute, we've followed up with those individual practices in order to address that variation to see what we can do to support them. Also, Taurus Healthcare, the local GP Federation, has produced a video for patients, and that's really to explain how general practice is operating now. It is very different post-pandemic, and it's to try and address the differences out there in terms of who you can see, because there are a whole range of additional staff that are now part of general practice. Workforce is the biggest challenge to general practice, as it is across the health sector. We know that the long-term plan in 2019 at that time said actually general practice in its current format is not sustainable. And at that point in time, part of the government's manifesto to increase access was to introduce a scheme called Additional Roles Reimbursement. This scheme offers a range of 15 different healthcare professionals that can work inside a GP practice and the wider primary care network, such as clinical pharmacists, physiotherapists, social prescribers, a whole host of those additional staff, recognising that actually a GP may not be the most appropriate person for patients to see. There may be others that would be more appropriate. In terms of raising the profile of that, we're in the process of the comms team of developing a leaflet that actually will help patients understand all of these different roles that are in general practice now. And we intend to publish and launch that. And really, we're going to try and do that via outreach teams and vans delivering COVID vaccinations and our social prescribers. So far to date, we've got about 187 additional staff employed via that scheme. I'm going to hand to my colleague now, Dr. Jonathan Leach, to talk about how general practice is operating from a clinical perspective.
Thank you very much. I hope you can hear me. So I'm Dr. Jonathan Leach. So I'm actually a GP in Bromsgrove. However, my local link, apart from being a GP for the CCG, is my daughter is Dr. Helen Leach, who's at Bromyard. So she's a young doctor and actually at the Bromyard and actually thoroughly enjoying her GP training there. So I've got Worcestershire links, but I've got Herefordshire links. So I'm just going to build on a couple of things that Charmaine has said. I think that from our perspective of general practice, and this is particularly nationally, never mind just locally, is the volume of work is just going up and up and up for all the reasons that Charmaine has said, not least of which, obviously, in my national vaccination role. Actually, Herefordshire and Worcestershire has done really well in terms of its ability to be able to vaccinate our population, and we wouldn't be sitting here if we hadn't got these vaccines. It's been astonishing. But as Charmaine has said, the particular problem we've got is workforce. Repeated governments have made offers to increase the number of GPs nationally by 5,000, 6,000. And actually all the select committees have actually said we won't meet any of them. And that actually is our major Achilles heel at the moment, insofar that we have an increasing workload, particularly as we have a growing population, we have an aging population, and particularly obviously it's in Herefordshire, it's also in Worcestershire, it's the same. But at the same time, we have, in terms of whole-time equivalents, the actual numbers of GPs going down. And that is a major problem. My generation, I'm going to share, I don't know if I should share this, I'm now age 62. It's unusual, but at my age, I'm working full time. That's my choice. But actually, many GPs, for a wide range of reasons, are now choosing to leave. So I think workforce is our major issue. The other comment I was going to make is about the balance between face-to-face and remote consultations. There's been quite a lot in the newspaper and by politicians, most of which has been ill-informed and unhelpful. That, if you like, the narrative is that face-to-face is good and remote is bad. Actually, that's incorrect. There are many patients who actually really like the face-to-face, but also there are many who like remote consultations, particularly people who work. And actually, as was coming from the previous speakers, actually, if they were doing remote consultations on sometimes quite complex patients with mental health needs, actually they can be facilitated, particularly if you've got somebody with agoraphobia and things like this. So actually the narrative about face-to-face and remote bad is incorrect. The trick actually is to get the balance right. There's guidance which actually I helped write through the Royal College of GPs about trying to get that balance right. What we have to do as doctors is listen to the patient, and there will be occasions where the patient says, I want to be seen face-to-face. And actually it's really important that we listen to that and deal with it. But also, there are many occasions where I'll say, look, actually, your problem is too complex, or I need additional information, that actually I need to see you face-to-face. And so actually it's about getting the balance right between the two. And that is perhaps the most difficult thing. I would say that doing a competent remote consultation, particularly on the phone, is probably the most difficult thing I do, because I don't have those non-verbal things in front of me. If somebody's in, I will know as a senior doctor, if somebody's very, very poorly, pretty well within a nanosecond of them walking through the door. Actually, I've got to really work on the phone. Is your breathing fast or slower? Actually, we have to change the ways in which we ask questions, rather than how we might do if you've actually got those non-verbal cues. I think the final point is actually, I think there are some bright things. I'm absolutely for the use of these wider healthcare professionals. The pharmacists, the additional nurses, the use of paramedic practitioners, actually they can be really, really helpful. They're part of that bigger team whereby actually we can deliver care. I'm also extremely supportive of the Three Counties Medical School. What we need to be able to do is to recruit and retain not just those who actually are going to be the students through the Three Counties Medical School, but actually what medical schools do is actually generate the staff who actually will work in them, who also then work in the university and also work clinically, and actually in other roles. So actually that medical school, which of course is across all the three rural counties of Gloucestershire, Herefordshire and Worcestershire, is actually probably one of the most positive things that I can see over the last 20 years that I've been living in Herefordshire and Worcestershire. Now, no doubt you'll have lots of questions. I'm going to hand over to Dr. Mike Hurd because he's going to cover off the very local things, but I hope that's helpful in terms of an overall context. Thank you very much.
Thank you, Dr. Leach.
Thank you. I hope you can hear me. So just to clarify, I'm a local GP, and yes, my role is Managing Director of Taurus Healthcare, but actually I'm here representing Herefordshire General Practice. So one of the things the pandemic has actually led us to collaborate on is ensuring that general practice actually works a lot more collaboratively, which I guess has been a huge opportunity really for us to address areas of access and other things that may be going on, vaccination being a good example where we delivered that program really successfully, but we did it particularly, the strength there that sat behind that was the fact that we did it together and worked in collaboration with other partners. So already I've emailed Turning Point just to ask them, what are the opportunities around working with the mobile van that they mentioned, because we're doing that with vaccination. We need to do that with health and wellbeing. So those are other opportunities that we can do and working together. I think it's worth also reflecting that just before COVID, really, we had the onset of primary care networks. Wasn't that long before that. And all this additional workforce that we're talking around, these new roles, paramedics, social prescribers, this kind of wider general practice team, which needs to merge with community teams and merge with other teams out there, with local authority teams, etc. Then we then had the pandemic, and of course, there's been a kind of a kind of mismatch, I guess, with regards to, is it my GP I can't see, or is it the GP team? So I think it's really important to stress is actually all context now. We talk about the wider GP team, and that's not just about how do we make the best use of the few GPs that we've got, because clearly that is a challenge, but it's really about the right person for the right part of the job. There are multiple skills across the kind of having a pharmacist to work and see someone about their medicines management is actually going to be a better job than senior GP in many ways, because they will address the detail that's needed with that GP oversight. So we're changing the role of a GP, and I think that is happening obviously all around the country. So the GP is becoming more of a conductor in someone's care. So they will overview it, they will get involved, but they'll get more involved with the complexity and the frailty side of things where they're required. I think it also is worth highlighting about the approach to a consultation is a journey. So it's not just one appointment that you might consider, whether that's face-to-face or telephone. It's actually a series of actually consultations and discussions that you might have. And telephone fits into that for some, more than others, and so does face-to-face with some, likewise with home visiting or using the wider team. And that has actually not changed. That's always been the case. Yes, the emphasis may have changed to more telephone because of the pandemic, but actually that's been to the advantage for some who want that. It's still actually making sure that face-to-face is available for those that require it. I don't think any of our GP teams would refute that. They're always going to be looking to support the right fit, the right place and the right time, and that's absolutely the case. I think it's also worth highlighting that in Herefordshire, we're also fortunate with regards to our approach to 24/7 general practice. This is not a thing that you have in most parts of the country. So we actually have a joined up primary care networks with GP teams working together. The Federation's job, Taurus's role, is to help pick up the gaps and try and make sure and provide a bit of glue to stick them all together and work in an effective manner with other parts of the system. And so the Federation also runs the out-of-hours service and an improved weekend and evening service. And the thing about this is, and what's different to other areas, it's all on the same computer system, which may seem like a small thing to say, but it's a big thing to deliver. And so therefore, if anyone goes to see someone in an out-of-hours environment, there's a degree of continuity of care there, as much as you can enable that, because you've got the same record, the communications there, you've got access to all the same things, as if you're seeing that patient within their own surgery. And then the final thing is about the workforce. We're trying to attract more and more workforce into Herefordshire, and clearly we're probably very fortunate, really, in terms of our baseline, because let's face it, it's a nice place to live, it's a nice place to work, and we've been shielded probably from the areas that certainly sit in the cities compared to in Herefordshire. But actually what we're seeing is that the workforce that we're attracting wants flexibility. The GPs want more flexible hours. It may be we're looking at sometimes term time hours and school time hours and different things like that, which actually needs to get evolved into job plans, which actually might think around building up the remote side of things that they can do from home, as well as looking at doing face-to-face access. So we're having to merge all these things together, which I think actually leaves us in a kind of forward-looking position, probably stronger than many parts of the country, given all the national challenges that we're seeing around general practice and increasing demands that have been highlighted already. So I think that's all I was going to say. Thank you.
Thank you. Thank you very much, Dr. Herman and the other speakers. I'm going to start by just making a comment about the vaccine rollout in Herefordshire, and congratulate the trust and everyone who was involved with that, because I have to say it's been extraordinary. I had my 2 vaccines at Elgar House, and the process was efficient, it was quick. And particularly I want to pay tribute to the volunteers who were helping doing the marshalling and the guiding. Absolutely brilliant, fantastic, 100% brilliant. And the statistics are impressive. You know, it's second highest level of vaccine in the country. Well done, absolutely fantastic. Well done. So I think that what we're dealing with today is, you know, is it a perception or is it reality? And that's what I think we need to try and pull apart. There's a perception, and it's been stoked in the national press, that there's a problem with access to GPs. And what I'm hearing is that there's now a multiplicity of ways in which we access a variety of services. And in fact, what we're doing is transforming. And it's happening at pace. It probably was already happening, but the pandemic's making it happen at an incredible pace. And perhaps what the problem is that there's lag. The public are not really sure. You know, they're used to accessing services in a particular way, and now they're struggling with a multiplicity of ways, and whether it's face-to-face or online or on the telephone, or whether, you know, and what it is. And I think that's maybe something that we're going to be trying to pull apart today and looking at where it comes down, because the report tells me that we've got 10% more appointments, and indeed we have more appointments than the national average with the GP. So what's the reality in all this, and what's the perception? But I think that's where we're going to go with it. I'd be also interested in whether the public, as it were, the wider public are also learning and changing. You know, is that a potential that we have? You know, is it? And how successful are we being in communicating this change, and communicating the dynamic nature of what's occurring, so that people continue to have confidence that whatever it is their need will be met. And so I'm just going to ask one question to start with, and then I'll pass on to the committee. So we're looking at, and I'm very pro the idea of having a team of people who have different things that they bring to the table. But at some point, somebody's making the assessment whether or not that patient requires a social prescriber, or whether they need a physiotherapist, or whether they need a pharmacist, or whether they need a GP, or what exactly they need. So at what point is that assessment made, and how confident is that person likely to be that that is the correct assessment? So I think it's probably for your question.
So I think, so clearly a lot of patients come direct to the practice in the first instance. So in fact, a lot of those decisions are initially made by GPs. But what we are doing is making greater use of, for example, pharmacists actually have been probably one of the biggest benefits we've had, particularly about the repeat prescribing, making prescribing safer, and also medicines optimization, which is, you know, for example, somebody's on asthma care, making sure that they're using their inhaler properly and things like that. In terms of the front door, the staff have been trained in terms of some of what's called care navigating. Some patients find that quite difficult, particularly if we're saying, well, you know, if a receptionist, as they perceive, is asking maybe slightly more pointed or more detailed questions. And I get that. But also, as we were hearing from Turning Point, or we had the same Worcestershire or for musculoskeletal, there's a greater reliance on patients actually if they've got a problem. Well, actually, for your back, you could go direct to the physiotherapist. And so some of this is around the navigation of that, as you described. Mike talked about a GP being the conductor of the orchestra, and I think that's probably a very good way of putting it. We do get lots of information back, and still, you know, I've got patients, I'm sure Mike's the same, who I've known for many, many, many years. And actually, you know, sometimes we will pick up, say, well, actually, in your case, actually, we would recommend you do something slightly different. And particularly if there's a sort of, maybe if we're talking about somebody with a back pain, that they've got lots of anxiety and things like this, that actually some of those sort of mental health treatments may be more useful than actually, you know, giving people lots of pills. I'm not a pill pushing doctor anyway. So it's a complex picture, which is actually quite difficult to explain. But I think that the issue is that what we're trying to do is utilise the skills, experience, expertise of other people, rather than it just solely being located on to doctors, given the fact that pharmacists do a 4-year degree. We've got paramedic practitioners who, very adept. Obviously our nursing staff is very, very experienced, plus a wide range of other healthcare professionals. I don't know if, Mike, you've got any other specific comments that you wanted to make.
Yeah, just to add a couple of things to that. Thank you, Jonathan. I think it's care navigators, as Jonathan said, is the key role from a general practice point of view, and they're always supported by the duty team. So duty GP, duty nurse, who works alongside them, and because they work in close proximity, there's a developing relationship there, which I think is the support that they require to try and help the patients make the right decision. I think the challenge that we have to ensure that first point of contact is always the right one is actually aligning where we are across the system, actually, to reduce confusion for patients. So when we look at the question that might go into 111 or the question that might be at A&E compared to general practice, that's a piece of work that we're trying to align. And that, for me, is the bigger question, actually, of how do we actually ensure that wherever people pitch up, we get the same answer. And I think that's where, that will be part of the evolving place-based discussions that we're having on urgent care. And that's something which I hope and have confidence that we'll address over the coming weeks and months.
Thank you. Thank you very much. Councillor Gandy.
Thank you. I was actually the member of the committee that raised this as an issue for us to consider as a scrutiny group. And the reason I did wasn't so much to do with the area I represent, which is a rural area. And in fact, on this occasion, I think that the rural communities actually fare better, significantly better than the city. And that bothers me equally. So there has been a number of letters in the press regarding the relatively new merged practice in Hereford, and I felt that it was worth sort of finding out for myself how this, whether this was any truth in this. So for about 3 months ago, which I accept was within the time frame of when you were still out there doing a significant number of vaccinations, I got my husband to try to ring that particular group of practices. And he did so over a 5-week period and never got to anywhere below number 25. And on many occasions was at number 50 and then cut off. I accepted that was the situation, and then thought last Friday, things are now, we should be in a slightly different and better position now. So I will try again. And we never got to position below number 14. And by chance, I met somebody over the weekend who is a patient at that particular group of practices, who pointed out to me that her mother had died recently, and she had tried to get through in order to report that, which is a distressing thing in itself. And she started off at number 34. And I can just imagine, and she made it absolutely clear how she felt hanging on to the phone for that length of time. So my issue isn't about once you get through, because I think certainly in my own area, I don't have a problem getting through, and I absolutely understand where it is important to have a face-to-face consultation, where a telephone conversation will work and where a video conversation will work. It is more about the patient getting through to get the option in the first place. And I think for residents in Hereford who were, I wouldn't say sceptical, but there was some scepticism about the merging of those practices. And I accept that it took place around about the time we had a pandemic, but nevertheless, I think some of their fears have been fulfilled, which is a shame. And I don't believe we should have a different standard for people living in the city to what we have for people living in the rural areas. So that's my concern, really.
Thank you. And I'm sorry to hear about these patient experiences that you've just outlined. The practice in question is a practice we've met with quite frequently over the last couple of months. They know there has been an issue with the telephones. If you think why HMG came about, it was 5 practices who had premises that were really not fit for purpose. They were not accessible for patients. They had a range of GPs, all of similar ages, coming up for retirement. And actually, we would have really struggled to recruit new partner GPs into any of those particular practices. So the merger was for all of the right reasons in terms of providing a sustainable general practice offer to Hereford City residents. Having discussed with HMG, I mean, I've been there several times. They've got a comms room, which they've possibly got about 15 people answering telephones at any one time. The day I was there, I think they'd received something like 1,700 calls by 2 o'clock in the afternoon. And in talking to them about what are you doing then about managing your telephone, they have given an undertaking that no patient will wait longer than 10 minutes by the end of March this year. Now, that's quite a change, I think, for some of the patients, because, you know, when I told you about the audit we did, some of the waits were lengthy. So they are working towards that. I met with them 3 weeks ago and they were on target for achieving that. Again, recruitment is an issue in terms of trying to get staff to come into general practice. We've had many receptionists leave because of the abuse and the negative press that's actually been put on general practice, many of them leaving for domestic jobs. You know, we've got a number that have left to go and clean trains because they can earn more money and get far less abuse than actually working in a general practice, which is really sad, I think. So we're working with them. They know they've got an issue. They know they are going to sort it. And we'll see where we are by the end of March, because that's their plan that we're working with them currently. Mike?
Absolutely echo what you said there, particularly around the reasons behind it. I just thought it was also worth highlighting the innovation actually that they're doing there, because I think it absolutely agree, and I know they're working on the access, but the things they're doing behind the scenes to address the workforce are actually things that we'll be seeing not just in other parts of Hereford, around the country, I think. So to try and look at innovative new ways of addressing that access. So they're getting patients to see mental health practitioners sooner. They're employing more, as an example. So it's yes about that wider team. They're doing more kind of looking at pharmacists and mental health workers, but they're also looking at kind of how do we deal with other ways of making sure that we free the GPs that we've got up to have them available to access, and things like the approach to when they look at blood results. They're getting in blood scientists, a role that's never existed in general practice. That's what they employ, and actually it is something which I think we're all going to see as learning, because I think other practices are further behind in this journey. Some might say thankfully, but partly because we've been shielded by being rural. I work in a rural practice. It's an easier place to recruit. It's an easier place, and we're shielded by it. But we're starting to see that change in the same way as Hereford City has seen the kind of challenge of workforce and demand. Inner cities saw that a few years ago. Bigger cities saw that before. We're going to see that in rural side of things, which is why primary care networks are there to try and help support that. We're going to be learning from HMG, but obviously access is the key thing that for us to learn from, and it also helps support them. And we're actually doing things at the moment, such as an additional remote hub to try and improve access, to see if that helps things with their on-site support. So we are trying to do some of those things, and it's good to hear about the action plan that's there. But it is a challenge.
Could I just add a little extra context, if I may, Councillor? In my own surgery in Bronto, we flipped our appointment system 10 years ago, so this isn't new. And what we did is that we went to essentially what we're doing now, and that was actually to improve access. I think the issue, I think there were various things. One is, as Charmaine said, is actually making sure that you've got a number of telephone lines and staff behind it. That's absolutely essential. you know, and actually we did that in a planned way. We actually did it over several months. We looked at demand and capacity. And of course, what's happened generally is that we've moved in effect from a more traditional model to a remote sort of, that's a big major part, actually pretty well overnight. We did it in 2 weeks. Whereas actually when we changed our appointment system, we did it over probably 4 or 5 months. The other thing is that for the first year, we don't get a large number of complaints. We're a pretty reasonable surgery, but we still have, you get some. And the number of our complaints doubled. We also had letters to our local MP. And it was all because there was a perception that actually we were trying to decrease access. We actually get very, very few now, because actually having explained this, and it's taken time for patients to understand what we're trying to do. We actually audited things like our cancer 2-week waits, because actually I would take a history on the phone. Let's say if I got somebody who was coughing up blood, I would take a history, arrange all the investigations, arrange all the bloods, chest x-ray, bring them in. Actually, the referral time referral time from actually reduced. It doesn't increase, it decreases. So some of this is about, and I think, Chair, you're right, it's about the explanation to the public that actually, this is a different way of doing things. The balance, as I've described at the beginning, is really important. But also the fact that actually there are advantages of being able to do this. It actually speeds things up. But clearly, to take up your point, Councillor, is that you've got to have enough staff to be able, you need enough lines and you need enough staff to be able to answer them. And actually you need to flex them, as actually GP out of hours does, so that there will be peak times. Monday morning, you need everybody on the phone. Doesn't matter what you do, you have everybody on the phone, okay? And then at 10 o'clock, you can go off and do other things. So actually they will flex the numbers of staff according to demand. And I think there's lots of things that we can do. And as I say, there are lots of us who have a lot of experience with this, but clearly there are other practices which, still have to sort of take the learning that we've had over a number of years. I hope that's helpful as a general context. I can't talk about Hereford Medical in particular.
It is helpful, and as someone that actually comes from Redditch, I do know Daventry House quite well, actually. But I think the issue, I think, that where I think this is so unfortunate, is if a patient has I worked at the Alexandra Hospital for 20 odd years, so I know that if a patient has a bad experience, either getting through, or if they do get through, it all goes wrong, then that is up there by the time they get to wherever they've got to go. They won't take it out on the GP. They never do. I mean, they never took it out on our consultant radiologists. They always took it out on the clerical staff. So they will take it out on the receptionist, which is really unfair. And there is a shortage of people who want to do these things. So I have absolutely no problem with changing the way that you do things, and things like EMIS and being able to repeat prescriptions and make appointments, etc., are really good and should be probably publicised more, because I don't think they're used often enough. But I do think that if you believe that you have a significant problem with regard to people getting through on your telephones, then you need to do something about it. And now is probably a long way down the line, and some of that bad faith is going to take a lot of getting over for people who've experienced have bad experiences. Thank you.
Councillor Tim.
Thank you, Chair. First of all, can I apologise to committee? I'm not checking my text messages. I'm having to use my phone because, despite the best administrations of the IT department, for the second scrutiny meeting in a row, I can't contact the internet. So yeah, as I say, I'm not checking my shopping list or anything. I don't know if you're responsible, Charmaine, or if it's the whole team, but can I just thank you, absolutely thank you, for a report which is long and full, but is utterly readable, which follows the gold standard that Councillor Gandy referred to earlier, every single acronym and abbreviation is put in full with the letters the first time it is used.
Yeah.
Thank you. It's an absolute joy to read this report. The only thing that's not a joy is that I should be having to make a song and a dance about it, because this should be the norm, not the exception to the rule. But thank you. It's a really interesting report. Quite frankly, I could sit and talk about this all afternoon and ask you a myriad of questions, but I think the chair might have a few objections to that. And secondly, may I also thank Councillor Gandy for doing an awful lot of my work for me. As a city member, the experiences that she relates are absolutely bread and butter, day in, day out, and also as a patient of HMG. I don't want to add to the stories, and I don't think I can match her husband's very fine work, but I have sat in clinic with a consultant who says, I'm really not happy with this, I'll just ring your GP and have a word. And I went, no. I said, oh, well, have you got a hotline? And he went, no, it's just the standard line. I said, you won't get through. And he went, no, don't be so ridiculous. And he picked it up and he went, it's just gone click. And I went, yeah, if there's more than 50 on the queue, oh, well, that's ridiculous. It must have misdialed. He dialed it again, click. And he went, well, I'll just have to leave you to bring up my concerns with your GP, which no consultant should put a patient under that sort of expectation. But I just add that to the anecdotes. I'm hugely impressed by the pledge of no one will wait for more than 10 minutes by the end of the month. I don't think I'll mention it to too many of my residents just at the moment. And in fact, since I need to get back into touch with HMG because they haven't got back to me after an online submission of results, we'll see how they're doing tomorrow, perhaps. So I won't go over a lot of the ground that Councillor Gandy has already prompted such really interesting responses from you, but I am very, very grateful. I do fully understand the problem. I thought that 8 point, if I can find it, 8.2 absolutely leapt off the report and hit me around the face. That says it all, really, as a a busy, casework heavy local ward member. Absolutely says it all. Public perception is that GP practices are not open, GPs are not seeing patients, and they should be returning to pre-pandemic ways of working. It's resulting in frustration, a negative narrative, often resulting in hostility and abuse of practice staff. That absolutely says it, Charmaine. It's that, as I say, leapt off the page, and I understand some of the measures that you want to take. I do think the getting people to take ownership and self-referral, I do understand it, and I hope it's aspirational rather than instant transformation, because it's something that I understand and I could do, but I certainly think a lot of my residents would struggle with. And basically, we're trying to turn around a culture of 75 years of go and see your doctor. So I don't think we should be expecting that to solve the situation in a short time. And I think, quite frankly, for particularly, dare I say it, for a lot of our older residents, it ain't going to happen. So I think we've got to look at capacity. I was going to ask you about your phone audits, but clearly you've addressed that. Just a couple of things that I would be interested to know a little bit more about. In 5.1, the talk of a virtual hub, how that is going to work, and the arrangements around that. And secondly, and this may be aimed slightly more specifically at Dr. Hearn, because it is, well, I'm saying it's Taurus-led, he can correct me. One of the biggest problems for my residents and for the whole of the South Y is that, of course, residents do feel a bit disenfranchised by moving all the services some way north of the river, and with our atrocious lack of connectivity in terms of public transport, let alone transport issues within Hereford anyway, by whatever means. And for a lot of South Wye residents, the loss of the Asda drop-in centre was profoundly felt. And however much I say, well, it is now a sort of a branch of HMG, and Taurus are there to provide out of hours. I would be grateful of your views on what more you can do to promote that and prevent it being seen as a sort of second-class option, or it's not really going to see the doctor. That sort of mentality, because clearly, certainly, that clinic is within my own ward, so it's within walking distance for many of my residents, and yet it's still not seen as accessible or as an option, or even as a proper doctor's. Thank you, Chair.
Thank you, Councillor, for those comments about the report. I'll pass that back to the team. So Taurus Healthcare actually run the virtual hub as part of the winter access funding that we've been awarded locally. So I'm going to hand to Matthew, who is basically delivering the service, his team across Herefordshire.
Thank you. Yes, so I think before talking around the virtual hub that we're currently doing, I think it's worth highlighting that during the pandemic, Taurus, on behalf of general practice, have been running the COVID management service, and that's been picking up, anyone diagnosed with COVID, particularly if they're unwell, a daily phone call through that period of time from a general practice team, and then would help direct any services to them if they needed that support. So we've learned a lot through that, is the background from that. And that same team has also picked up these specialist drugs that we have for people to keep them out of hospital. And they're still currently doing that, as well as delivering the COVID management service team. Alongside that, we also have the community teams that's Wye Valley deliver on, alongside working with social care. They look at providing something called a 2-hour response, which I don't know how familiar the committee is with that, but actually that is designed to try and keep people out of hospital and try and make sure that it can support their urgent needs in the community with nursing care needs, etc. And this same hub that we're talking around, that we've been building on with the kind of medical inputs, also provides some medical expertise and oversight into that 2-hour response. And I highlight that really because it's the level of integration which I think is key to some of that working. And so some of the building up on that recently then is, well, how can we actually support access to general practice? And there's been an initiative which is around winter access and improving access to general practice. So we've set up a virtual hub. Effectively, you phone your own GP surgery still. And as a patient, you are asked if you would like your care to be delivered. You felt it could be delivered remotely by phone or video. And if the answer is yes, and the care navigator answers the phone, decides that that was also appropriate, then they're put in for this virtual hub. And we're doing that currently with 3 surgeries, so that's HMG included, to try and ensure that we've got a wider team available to support them. The advantages of this really is this is something that if we can sustain this, and that will be a funding question across many parts of the system as we move forward, the key to this will be it provides general practice for the first time some resilience that it could look at that is much more easy to switch on. So you imagine, as particularly in a smaller surgery, if you have a GP who's suddenly off sick that day and causing, you just have to literally cancel the appointments or everyone else works harder. And that's created some of the workforce crisis that we're in, is that pressure has become bigger and bigger, and people just don't want that anymore, and they're struggling to really sustain that. So building some of this resilience team, working with remotely as well. And we've got GPs who work for us in Liverpool, got London, we had one over through the pandemic who lived in Geneva. And I think who knew Hereford, I hasten to add, but happened to be geographically located elsewhere, who knew the local system, had access to the record, and it just gives Herefordshire actually a really good chance of actually providing additional resilience that we wouldn't otherwise be able to achieve. So I'm hopeful that the virtual hub will build. I'm hopeful that it will also look at seeing how we can support A&E and people who perhaps turn up there, not always the right place at the right time, let's be honest. And I'm also hopeful that we'll be looking at how we can work with the virtual hub to support one-on-one, because I think that regional side of things needs some localism, which would add, I think, to the quality of triage or right care and treatment at the right time. So that, I mean, obviously, is the virtual hub side of things. The improved access side of things south of the river. So tourists provide the kind of evening and weekend site service. And again, that's about striking the balance between trying to, the level of integration that you're trying to get across all services and where patients are best served. And clearly, yes, we do the service there, but we also do a service at Station Medical Centre. And one of the questions for us is how do we make sure that we address the needs of that population? So is it actually in that local geography as an example, or do actually people end up pitching up more to A&E? And it's a really difficult one, that is, because of course A&E is in a different part of the city. And I think what we do see is a lot of people do end up going to A&E as it happens, with rightly or wrongly. And it is one of the things we need to pick up and work through is where is this care best delivered? How do we link in with other partners, as well as making sure that patients get the kind of direct access that they require? Always difficult to strike the balance, and that's where we're continuing to work on it. So I can certainly assure you that we're supportive of making sure that there are services south of the river. I think that's absolutely the case. But actually, in terms of where hubs are located at times, I think it needs to evolve, and it may need to move at times. But that's something that remains to be seen.
Although, with respect to, but I think the point I was trying to make is actually the promotion and awareness of that hub, and of it being seen as a genuine and legitimate alternative to going to station approach. Are you happy that there are sufficient appointments there and sufficient appointments available to be offered and things like that?
I think in terms of sufficient appointments there or at any GP surgery, I would struggle to say that there are sufficient appointments necessarily that would always cater for the demand. But it's about making sure that you manage that demand in the most appropriate way. Hence the phone calls for some people. So some of that the requests will be dealt with on the phone. And then there will be some face-to-face access delivered there. One of the things we struggled with, you mentioned EMIS before, and that's the GP system, is what we rely on in terms of making appointments is patients doing it through their GP surgery. Unfortunately, the system doesn't allow us, because we're trying to lobby the national EMIS team around this for a few years to try and promote direct access for patients, because that's really what we want to do. And if we could do that, that would make things a lot more effective and efficient. And I think that would probably answer a lot of queries.
You mean direct access to booking appointments? I mean, because that used to exist.
Not for the evening and weekend service.
No, but it doesn't exist at all now. I mean, I think that was sort of. I appreciate this isn't aimed at tourists, so it's. Do you see a time when EMIS will go back to allowing patients to book appointments with HMG or anywhere else? I'd say it may be a question for Charmaine.
I mean, certainly NHS England are that the mandate for how general practice office operates is a triage first option. And certainly we've seen the new operating model for next year, and it's exactly the same. So there will be a digital triage first, but there will be an offer where patients can see a clinician of any type, not a GP necessarily, the ability to be able to book. So it's going to be a mixed model, I think, moving forward. We're not going to ever revert back to how it was.
No,
it will be a very mixed model.
Because I've had conversations with the patient group, going, well, clearly booking appointments with a GP would go directly against much of what you and the report had to say. But I think there's a halfway house of at least being able to book blood tests, for instance, rather than sitting as number 37 on the queue just to book a blood test, particularly when you've been instructed to take a blood test or a medication review or you know, many of the sort of appointments with the wider team that we've been discussing. So, you know, I certainly would hope that that is something that's in the foreseeable future.
Yeah, I can see that there will need to be a way of looking at that. I think the balance to strike is ensuring people get the right blood test, for example, that is required. So if we opened up blood tests to patients and anyone could look into that, I would be confident that there would be a number of blood tests there that shouldn't be done at all. Some blood tests that have been done far too often, and some actually are missed opportunities to add additional blood tests. So the challenge we have is trying to ensure that you get the right balance of clinical input into that to make sure the patient gets the right care.
I can book appointments on these.
Ooh,
I've just done it. I've just done it. I've done one, but
I was surprised. Yeah, I think you can book. There are
not on HMG. You can't. Not if you're HMG.
There will be a variability in terms of that, but actually that's something that will be looked at. You can't book in the evenings and weekends. Oh, shut up.
I think actually one instant piece of learning here is that there's something that might be improved in terms of comms of what you can do to agency and other, you know, places. So you can book online, you know, why are people holding on the telephone for hours? It doesn't make sense. I can only assume they don't know they can book online.
But I say with HMG you can't now anymore. Anything.
Right.
Other, you can do repeat prescriptions.
Okay. Councillor Summers.
Thank you, Chair. You know, it doesn't matter where one sits on the hierarchy of services, it's the frontline staff that take the brunt of the abuse, and that's the shame about all this. One of the biggest issues in the world is probably communications, even more so between GPs and patients, and hospitals and GPs. The communication between hospital and GPs fails so many times. Discharge letters. If you talk to the hospital, they say you talk to your GP. If you talk to your GP, they say there's a prescription with it, or talk to your hospital. So that's an issue anyway, where we need to look into, because communications is the root of all evil, probably. And I think we need to come to terms on that and put more out there. Vulnerability, for example, as far as COVID is concerned. If you think you're vulnerable, it's up to the central government to say whether you're vulnerable or not. Yet your GP knows patients better than anybody else, so shouldn't they be saying who's vulnerable and who's not? So there's a few things here, but most of it all comes back to communication. And if we can improve that, I think we'll get somewhere. So if you can see anything in the future about communications, I'd appreciate it. Thanks.
Can I come back on that? That's okay. Just to highlight, I think picking up the example during COVID vaccination, a number of times people were wondering, where do we go? What do we do? And even now, still we get those questions raised. So I would suggest we are expanding the use of the Herefordshire General Practice website. I appreciate that doesn't get to everyone, but actually, if you want a place to go to look at COVID vaccination, that would be the place. On there is also some work done on how to access care. And what we're trying to do is to try and ensure that actually some of that information is more visible to patients. And I'd like to be able to think that over time, we'll be able to provide more patient education, more materials, so that actually it is not just a sending people off to a website or a video that nobody, someone that nobody knows or has come across. What I'd like to do is that this is a point of bringing together all of the local GP surgeries, recognising that they can't all do this 24 times. It's actually, how do we bring this together to ensure that we try and do some of this once where it makes sense to do so, if we're doing all the same thing. So that is the hope, is that we'll be expanding that. So I would urge your colleagues and communities to consider actually looking at that site to sit and help us develop that, to make sure that we can get that point of contact for you.
Okay.
And if I could just pick up the issue on vulnerability to COVID, Councillor, I'll put my National Medical Director for COVID vaccine hat on for a second. There's actually been a huge amount of work done right across the country, across the world, in terms of trying to understand which are the either patient age, conditions, which actually gives you greater vulnerability. I particularly point you towards, in the UK, the work done through the University of Oxford, what's called a Q-COVID study, which actually pulled out a lot of data out of general practice and looked at the interrelationship between the coding or conditions that patients have, and then also with their admission rate to hospital, and unfortunately those who died. That actually turned round and actually has been incorporated into, for example, the vaccination strategy through JCVI. It's also been incorporated into the data that we're given in general practice in terms of who we should prioritise in terms of vaccination. Just to reassure you that actually, because we recognise that the data is not 100% accurate, it's the data's the data, so garbage in, garbage out, so to speak. There was a flexibility, and there is that flexibility, that if I've got somebody who I consider to be very vulnerable but isn't being picked up by that system, that actually I can add them to it, so that actually it is then identified, both in terms of vaccination, but also in terms of actually, as we're now starting to use some of these antiviral medicines, which are actually really important. But I do take your point about communication, in terms of actually, the timely, accurate communication between all parties. So that's the patient, us as general practice, pharmacy, and our hospital colleagues is really important. But I just thought I'd just sort of provide a little bit of extra clarity about some of the vulnerability identification.
Well, thank you very much about the vulnerability, because I didn't know, and I'm not sure anybody else knows about it. So just the one question that I think everybody's asked over the years is communication between hospitals and GPs. It seems to be, sometimes it's good, I'm not saying it's always bad, but a lot of the times, for me, it's been 80% of the time, it's been very poor. So any answers? Are we looking forward to changing that system? Are we looking forward to making more reference between GPs and hospitals? I don't know. Maybe you can answer it. Thank you.
I think I'm going to, if I take the formal things, and I'll take the informal, actually. The formal things is that when somebody, is seen in hospital, whether that's admission or an outpatient, we get a letter. And actually the good thing is actually over years, we now just get that electronically. So actually we get it really quickly, rather than, waiting for somebody to look a second class postage stamp, which was essentially what we said. So we do get that much more quickly. We also get a lot of information which previously took ages. For example, as soon as somebody has that MRI or that X-ray, actually we can now access that in general practice, whereas previously we weren't able to do that. So there's lots of things which are better. There are also, the letters actually generally are very good, and they're generally very informative. I think my comment will be, though, that we've lost a lot of the soft elements, which also happened. So, as I described, that's rashly, as a senior doctor, routinely we used to attend the hospital and things like this for postgraduate meetings, and we would have our meetings with the consultants. Quite often, if you're like, oh, I saw so-and-so in the corridor, last week, what do you reckon? Actually, we've lost that. Yeah. We've lost that not just with our hospital colleagues, we've lost that with our health visitors, we've lost that with our midwives. And I think that my regret at the senior end of my professional career is actually that's very much to our detriment, because we're using formal things rather than the informal. Now, documenting and thing is fine, but sometimes that isn't what we need. But I'll be interested in what Mike says, but actually some of those informal things where you have that personal relationship. I used to be able to say, right, okay, Mr. Jones, I'm looking that name up, is the surgeon. Let me ring him and see what he thinks. I don't know the surgeons in my local hospital, and I would expect here in Herefordshire to be the same. And I think that I have that regret, but it would be the other way around as well. They don't know who we are. And actually, I think that is to me, that is a retrograde step. But I'd be interested to see what Mike says.
Thanks. I don't disagree with the challenge, obviously, of that communication, but things have improved. I know that there was some delays with the A&E discharge. It was only until only a few months ago, actually, and actually that's been resolved. And I guess I would highlight the there are some things which, those corridor conversations, those meetings where socially don't happen as often, clearly, but pandemic aside, but there have actually been much more positives in the sense that the communication between general practice, local authority, the mental health trust, and the acute trust, I don't think have ever been so good. So it's an interesting dynamic, really, because we meet literally every week. Mandy and I, we've never used to meet, did we? Now all the time we meet. I meet Paul every week. And I absolutely get that's not everyone meeting. And I get that, that's me and 2 or 3 other colleagues from general practice, and we will discuss all of us any of the areas that we might see that are causing us all challenge. So what are the niggles? What's the problems? Where's that delayed discharges? That's an issue, and it can be just the basic stuff that we discuss. And actually, it really gives us a good opportunity to highlight those. And I think certainly with general practice, what we've done by working together more collaboratively and working as one, they now know that I go to those meetings and some of my colleagues go. They raise those issues with me and I feed them back to them. So whilst it's not the corridor conversation of old, and I absolutely, love those, and I'd love to go and have a curry and a beer down with some of the consultants like we used to do, but we haven't, we've moved it on now to the point where we're doing it in a little bit more of a uniform fashion, which actually brings around the change if we do it in a more effective way, perhaps better than we used to in an informal way. So I think I've got mixed views on it, but it's but I think in terms of integration, I think we're much further ahead than we ever have been in my time in Herefordshire.
Can I suggest, just as a result of some of that conversation, in particular around the GP website and engagement over that, and that we put that as a recommendation that we would like to be cited on that, and perhaps there's a role for Paul and talk community in me, because it seems to me that one of the strong messages I'm getting from this is that there is an issue with public perception, and that we do need to encourage the public to realise that actually this is an increase in choice, an increase in different ways they will access service, and so that they go along with it. I'm interested as well in whether or not there's any further potential in kind of winnowing out telephone contacts. If you're getting these kind of huge bursts of activity in the early morning, whatever, is this all about making appointments, or are there people phoning to get the results of their blood test, or people phoning to tell you that someone has passed, or whatever, So is it possible to do a piece of work to triage the telephone contacts, as it were, and try to divert a number of those contacts away to other more appropriate methods of communication, whether it's email or whatever? Is that something that's underway?
Thank you. So I'll talk about the telephone system. So at the moment, we are investing in all Herefordshire general practices the ability to have a new internet-based telephone system, which will allow them to have greater data in terms of what is coming into the practice. It will support them in terms of managing their workload. So how many calls do we get? There's a lot of reporting that comes out of it, and some really valuable data that practices can then look at. Okay, what are the peak times of our calls? How are we going to manage them? How can we triage them appropriately? In terms of your question around can we siphon out really various queries, that is already happening. Mike, I don't know whether you want to give an example from your practice at Found Hope about how that works in reality.
There's a couple of things about, direct access to blood results is one example that you can get. I don't think everyone does do that. I haven't said that. I think there's a lot of people who still come through on the phone when they could actually get direct access. And the other one is online consultation. So every GP practice will have access to an online consultation, which is effectively where you go through a triage set of questions. It helps you to identify whether your need is more urgent, and if it's not, you're able to clearly articulate what it is you require. And actually being on the other side of that, it's really helpful, because you see right at the start, someone may just want a sick note. For instance, you already know them. You don't actually need to bring them up at all. And you just send them a text saying, here's your sick note, because you know them well enough to be able to do that. And there'll be other opportunities for managing their care effectively through those online consultations. So that is also, I think, a really effective mechanism for contacting the surgeries. But yeah, I think a lot of people still come through on the phone just because it feels like it's easier. But let's be honest, in terms of if you try and change your gas provider, it feels like it might be easy on the phone in the first outset, but it never is. It's always easy on a website.
Yeah, but I mean, that's an interesting point, because as a society, we're learning that it's not easier on the phone. You know, I mean, I think we're all on that. You know, we think, oh, I'll just pick up the thing, oh, no, let's not do that because I've got to wait 1,000 years, so I'll just do it online. Although with my broadband speed, it's sometimes quicker on the phone. But clearly this is changing, you know, across society in a million ways in which we access services. Are you engaged with patient groups to sense test and to actually try things out? Because sometimes what might appear to be a blindingly easy way of accessing it, if you're actually on the other end trying to do it, can be torturous and difficult. So have you got mystery shoppers doing it?
So all practices have patient engagement groups, so they have their own patient groups where they should be gaining feedback around how their services are running, how they're being delivered, how they're being operated. And equally, we engage from a CCG perspective with the national survey. So what are the patients telling us? What's the feedback we're getting? And actually some of the feedback was what led to, not mystery shopper, but an audit that we did by the CCG that actually practices didn't know we were doing around how long does it take to get through on the telephone? What are the messages on websites for our patients in terms of access to a GP practice? Mike?
Can I just add to that? Because actually Christine is on the line as well. Hello, Christine. And I'm just conscious that from a HealthWatch perspective, if you don't mind me saying, Christine, is one of those things, isn't it? It's about how do you join up the various PPGs. And so the community partnership that's part of the kind of developments, again, I'm not sure how familiar you are with those, I think is going to play a key role in how we perhaps avoid having a patient group for general practice and a different one next door, actually, because it's about how well services work together and evolve all of the things that all of the offer. And indeed, Christine, we've got, I think on the website I referred to, there is an urgent care video, which is for patients how to access care urgently. And Christine posed a number of questions to us, to me, to a pharmacist colleague, an optometrist, an acute physician at the hospital, with the idea of trying to understand, you know, where do you go? Because it's always difficult. And I think that's the relationship that we need to do, is to make sure that HealthWatch support us and equally challenge us with some of that development moving forward.
Thank you. This is such an interesting subject. Really, we could. I was absolutely saying we could be at this forever. But we are not, because we have other things to go on. Councillor Marsh.
Yes, I know many companies flip their queues by going, you really don't need to stay on the line, we'll bring you back within a certain length of time. And that would seem to me to have considerable merit. And the other thing is, I think you're never going to come up with a tidy top-down navigation anymore. It is going to be a sort of fungal network. And what we need, it's not going to be tidy that you should start here, but what we need is a network that wherever you start, you do move to the right place. And the care navigators are going to be critical to that. And I just think it's tragic that you are losing care navigators to clean trains. I know we're very proud of our own community care brokers, and I think they are well above the minimum wage. And I do feel that the navigators, who I must say I suspect are mostly women, do need an opportunity to grow and progress in their field and to have a decent remuneration, because with these 15, you know, very fancy specialists they work with, it's really important that their role is really taken as well. And then the other question is coming back, as everybody has said, to how we can efficiently link people in to somewhere on the information network and be confident that they will go through. And finally, as I'm a Leinster councillor, I couldn't possibly not say that Leinster is, of course, preparing for a transition, as has happened in Hereford, I hope in slightly less challenging circumstances, where outdated premises and an older cohort of GPs are looking forward to a more collaborative and inclusive style of working, which I personally think will be a great deal more attractive to young professionals coming through than the rather old-fashioned and isolated experience that being a GP or working at a GP's was before. So I think there is much to welcome, but as everyone has said, it's going to be having the greatest number of people who can go, no, it's going to be all right, you know, start here, and can point the people to something where you can enter in will be helpful. That's
Okay, is there any member of the committee got anything further?
I think I'd be remiss if I am afraid I would be remiss if I didn't bring up mental well-being. It seems to be, we're getting there, but we still seem to have some ways to go. I'd like to see more GP practices, more mental health, not necessarily to actually save the doctors some work. We had somebody that was mental health being trained that could see patients that come in with mental health and would be their first stop, and then they could be moved to or sent to where they were best be served. Is there any thought to more? I know there's some GP practices that have mental health in their practice. Is there more? Are we going to more than that? More? I know from Herefordshire and Worcester, there are a few in Hereford and more in Worcester, but how are we doing with it?
So mental health practitioners are one of the roles that are part of the additional roles reimbursement scheme. So one of these 15 roles where general practice can actually, or PCNs, can jointly employ mental health practitioners with the local mental health provider. There are changes in terms of how that operates from 1st of April next year, which will actually make it easier to start bringing on those mental health practitioners. But of course, like many of the specialties in workforce, there is a shortage of these particular practitioners. Now, the changes from next year will allow that, I guess, the movement through the profession through the grades. So actually it will enable far more people to become part of this additional roles sooner rather than later. So there is a move in terms of bringing those additional staff on board.
May I ask what kind of response you're getting from the GP practices themselves? I know this has been in the works for some time now, and there are, could you give me some ideas, please?
Yeah, absolutely. I mean, I certainly can say that, you know, I meet the medical management mental health teams every 2 weeks, really, just talking through some of these things. And general practice is very much behind getting as much mental health as can be catered for in terms of the mental health practitioners. But I think it's also worth highlighting that that's looking particularly at the reactive element of things, and it's also important how we address mental health, looking at more prevention. And so that there are pockets of, you know, certainly North and West at the moment. The North and West Network has a health and wellbeing team, which is health and wellbeing coaches working with social prescribers, working with the mind link workers, and connecting with some of the kind of work that the local authority does. And I think there's sort of options for thoughts around how they work in Halo. I think, you know, opportunities around exercise, etc. So that for me is the really interesting stuff as to really take that forward. The next step, which I'm very positive to see happening in parts of the county.
It sounds very positive. Would that be similar to the diabetes one that's been working now that you have so many possible diabetes patients and you're working with them? I know my wife's on a team now, and there's about 20 people in that, and they have phone calls every day. Something like that would be very useful. Anyway, thank you.
And I think the other one is, you know, sort of, we've got quite a large number of military veterans in Herefordshire. So I'm on, okay. So, putting my national hat on again. We've done a lot in Herefordshire, actually, both with the camp and also with the wider GP practices. We've got quite a number now who are what we call veterans accredited through the Royal College GPs. So you have a clinical lead. But actually, some of picking up what Mike was talking about, some of the things which are really important are for example, having your friends, your comrades, your colleagues around you. So, for example, I have been to, for example, the Veteran Sports Centre here in Hereford, where people can get that mutual support and peer support. And actually, in terms of prevention, that's probably the most important thing. What we then have, and this is right across the West Midlands, and I helped set it up, is the Veterans Mental Health Service. So actually the key performance indicator for somebody who's referred is actually they're assessed within 2 weeks. So there's also issues around access to high intensity services, and also we've got, and there have been a number from Hereford who've required what's called a complex treatment service. This is all part of what we call op carriage. So where we've got the county such as this with a long history of military patients, and particularly those who settle. Actually, this has been one of our particular focuses in the West Midlands, and obviously with me being Worcestershire based and as the National Medical Director, I've made sure that, if you like, Herefordshire and Worcestershire are actually, provided with these services. But I think you were talking earlier to Turning Point about self-referral. It's 70% of referrals to the Veterans Mental Health Service nationally are by self-referral or referral by charities. And actually, they're then assessed in terms of whether or not how much of a problem it is. And sometimes it's related to, have they got a house? Mm-hmm. Do they need support with a job? Do you need support with your debt? It's actually not a medical problem. And if I just say this may interest you, when we've been setting that up, I'm more interested in how many people have a house and a job than how many prescriptions for antidepressants I prescribe. But I hope that's an interesting, it's sort of indirectly relevant here because of the population. But we've done quite a lot here on that. If you want to ask me about that, I can do. But obviously that's wearing one of my other.
I mean, that actually would be a fascinating conversation on another day.
And another day. Since I'm local.
So I'm just going to see if Christine Healthwatch, you've got any comments that you'd like to make at this point.
No, nothing additional that hasn't been covered already. Just to say that we did do quite a bit of work with Mike and Taurus in July when patients were coming forward with a lot of concerns about access, because I think the biggest issue wasn't really that that they weren't getting an appointment, it was that they weren't necessarily getting what they expected. And I think we recognise that the piece of work, as you've identified, Chair, was actually about communicating more effectively the different roles, the way triage works, care navigation, and informing the public a bit more. And I think there's probably a point where you can always do more, and I think collectively we perhaps all need to just keep pushing on that to make sure that the public get those messages.
Thank you. Yes, I think that was a good point as well. So we are all collaboratively responsible for doing some of this work. So have we got any further recommendations or anyone wants to come forward with this point?
The community notes the measures being taken to improve patients' access to GP services, and that the committee recommends that information be shared with the committee on how avenues for contact with healthcare providers are communicated to the public. The executive considers the role of talk community in promoting these avenues.
Councillor Sanders?
I would just like to put an emphasis on the communication between the hospital and the GPs, because they send, there's two ways of sending the discharge letters, either sent with the patient or it's mailed or it's sent electronically. I'm not sure what, I know mine was sent, I took physically, but I think there needs to be some communication between hospitals and GPs, because there is a tendency to pass stuff on. This is not our domain, it's the domain of someone else, etc. So I'm not sure how we can get around that, or how we can.
I'm not sure if that's relevant really to this.
It may not be. It's just
about face-to-face access to GP services, not about communication between GP services. Okay. But I'm sure your comment has been heard by our colleagues. Thank you. Any further on that recommendation?
Jenny wants to say something. Oh.
Yeah, she comes in after we've agreed.
Oh, right, okay.
So we agree that recommendation?
Yeah.
Thank you. Councillor Bartlett?
Thank you. And thank you for the report that everybody's just presented. It really is a very good report. It's very useful. I think for me, I would just like to ask people to look at the section 8 on that campaign, because I think it's really interesting as well that not only the work with Christine and Health Watch, but one of the key partner things to consider is how well is the NHS 111 system working, and how that is working together with the GPs to manage where people should be going to the right place, right first time. And also, really, it's to look at how that triage is working for people when they get to the first point of contact. Where do they cascade down the system? So on that plan that they've got, it would probably be quite useful for you to get some feedback on that at some point, whether or not the plan's actually working.
Thank you. Yeah, so section 8 very much deals with the comms campaign that we have been leading from really last October to date. And clearly we're not getting the messages to the right people from the feedback we've had today, no matter how much we're pushing advertisements on social media, in local papers, on the radio, local radio stations, people are not still hearing. We are again in the process of developing a further video that our comms team are leading, which will very much focus on the individual additional roles that are in general practice. So again, we will be pushing that out via social media channels in terms of in raising awareness really, and trying to inform patients about what they may expect.
I mean, somebody said earlier, we've had how many decades of doing it one way. This is not going to change overnight. It's a process.
But Chair, with all due respect, I was thinking we know where we are at the moment, but it would be nice to get some feedback in future about how that campaign panned out.
Thank you, Councillor Bartlett. We can always put it back on the work programme if we want to look at it again.
Can I just a tiny specific question on that point, Charmaine, probably. Is the monitoring of this campaign going to continue? So, for instance, the phone audits, will they continue to make sure HMG, for instance, do get to 10 minutes by the end of March, and other targets, of course? Yeah, I thought we can't leave it to Councillor Gandy's husband all the time.
Very helpful it is, Councillor. So yes, we will continue. So we place, we review the National Patient Survey quite significantly when that comes through on an annual basis. Clearly as well, any reports that Health Watch undertake locally, we conduct further activity around that. I mean, the one thing to say is, a GP practice is not contracted to answer the phone within a certain time, but equally it's a far better experience for the patient if it's sooner rather than later. So we will continue to audit general practice in the way in which we've done in the past.
Thank you.
Thank you. Thank you all very much. We just, yes,
sorry, just one closing comment. I just thought it might be worth highlighting that if we go down this road again looking at access to general practice, then a measure perhaps of the integration that we are talking around, maybe around access to health and social care services in a collective, because I think that's where we're going, that's what we're trying to do. And actually, I think looking at individual providers probably only gives part of the story, so it may be worth thinking about in the future.
I think, yeah, so thank you for that. That's a very good idea. I think we might consider that as part of the work programme going forward. It's these points of interface that I think are the most useful for us to discuss. Okay, so we still need a vote on the recommendation as it stands. So we have those in favour, show. Against? Any abstentions? Okay, so thank you all very much. Thank you, Charmaine and Dr. Helen, Dr. Leach. It was very, it's honestly could have carried on talking about that forever. It was very, very interesting.
There's such a long list of questions here. I've censored. No, don't ask that. Time for that.
But we're obliged for your time. Thank you.
Thank you.
Right, so item 10.2, healthcare. This is an update. We have Mandy Appleby, Assistant Director, Adult Social Care Operations and Public, Associate Director, Quality NHS Herefordshire Worcestershire CCG, to introduce the item, which, as you know, committee members will be aware, we have scrutinised this a number of times previously, so I'm not expecting a scrutiny, but rather a note of the update.
So shall I start with the briefing for you, which has been largely written, actually, authored by Jane Aldrich, Associate Director in Herefordshire Worcester CCG. I'm Mandy Appleby, Service Director for Adult Social Care Delivery, in case there's anybody that doesn't know who I am. You're right, Councillor. We had I think we started to scrutinise CHC since 2019. There's been a range of questions and papers coming to and from scrutiny, inviting the then CCG and Herefordshire Council to ask questions. The new Herefordshire and Worcestershire merger of the CCG happened in 2020, April 2020, and even later than that, Jane arrived. And I must say that since Jane Lodwick has arrived, along with, to give credit to Lisa Levy, in CCG, I feel we've really moved on in developing a much more resilient approach and joined up approach to the issues that we felt needed to be progressed. We put to you today, and we can answer questions as you ask, a paper which we been as transparent as we can be with regards to national data, and also extrapolating from that national data, which largely often includes Worcestershire as well, making sure that we eke out the Herefordshire component of that, so you can see that within the report. I think that we've now, my personal professional opinion is that we've now moved to the point where we've really got a joined up strategy, joined up policy, procedures and training schedule, which really will put us in a very good place in Herefordshire to meet the needs of Herefordshire citizens within our statutory duties towards the CHC framework. So whether you want to ask questions, we covered 5 main points, which were the outstanding points and questions of, that we, from what we could elicit from your previous meetings, A to E. The only point that we haven't tried to address is scrutiny's previous questions about the minor injury units, which the CCG is going to address separately to this. Otherwise, I trust that this report, that you'll find that it's going some way to answering all the previous questions that we can make, taking note that pre-2020, the merger, there's practices and the ways of reporting is different, so we can't sort of compare apples with pears, and some of the information actually hasn't been obtainable, but we've pointed that out in the report where that's not so. I'm hoping that you'll find that there are appropriate explanations for any abbreviations. I have had a quick frantic
If I carry on terrorising them enough, we won't get what we need.
That has been duly covered, but there might be 1 or 2 slips. Which,
I've got a couple to.
Over to you for any questions.
Thank you. So thank you, Brayden. Thank you for I thought it was a positive response to the various queries and challenges raised by this committee over a period of time, and the response is duly noted. And it seems to me that there's a dynamic system change in operation here, and that therefore the level of change is to such an extent to make the kind of questions and concerns of a year ago being somewhat irrelevant nowadays. So maybe this is something that we will look at again once the change is complete and we can have a, but clearly that, you know, everything is shifting. Is that fair? Yeah, Jen.
I think fundamentally, when I came and met with you previously, I was 3 weeks into a new role, and I went away with a very clear idea of what your concerns were. But we're fundamentally already so different in the way we work together in 6 months. And I just think that that's on a journey of working collaboratively, working together, being very clear about what where the areas of challenge, the areas of perhaps weakness in what we've done historically. But actually, I mean, in my team, there's been fundamental change in terms of personnel, in terms of processes, in terms of scrutiny. And I think that really plays out. But we're absolutely on a journey. I said I was going to do a system-wide review of CHC. We're on that journey at the moment. We've started that process. But already we've got an ops policy, we've got meetings. For me, we're working in a fundamentally different way than even we were 6 months ago. And I'm really, really positive and hopeful that will just continue.
That's good. It's really good to hear. And so that being the case, I think for myself, I think the sensible thing at this point is to take this response as the final word on the CHC subject for this committee for now. And the committee reserves the right to return to the subject at a point in the future if further concerns are raised or if we have further concerns over it, unless anyone has a specific question relating to the report. Councillor Summers.
Thank you, Chair. The only thing that I have is after discharge. It was fairly new previously when you first came on board. It's something that's growing. It's something that's now being put out by central government. I think we need to follow up on that a little bit more. Other than that, I'm fine. Thank you.
I think, are you referring to discharge to assess and the processes that were brought in through COVID?
Yeah.
So those processes are still ongoing.
Yes, I appreciate
that. They've been adapted and I'd say improved as you know, as we've got to know. There's still work to be done, and of course, the final position going forward on discharge to assess around its funding is still to be made. And how we commission for those services on a long-term basis. But practice-wise, I'd say that we have fundamentally shifted, but absolutely by working together on our systems and processes.
And that's what I felt also. And just that I think it's probably you and talk to the community together that would really work on this one, I think. So I'll leave it. If you can come up with it another time, I'd appreciate it. Thank you.
Thank you.
Could I just ask a short question on table 7, where it shows the change in numbers and the children's numbers have more than doubled, and I wondered if you could tell us if you think that's a sort of backlog or whether this extremely rapid rise is likely to continue, and also whether some of the young people may be on CHC for 40 years. I mean, I'm just thinking that will make a huge difference to the budget, you know, compared to people who, older people who might be on it for a relatively short period.
I think children's continued care is a really challenging issue. It's a different framework from the adult framework. Both are under me. I'm an adult and a children's nurse. I have asked for a system-wide review of all things children across Herefordshire and Worcestershire because I think we need to understand it's a different picture from the one I was expecting to see. So really, I'm looking for assurance that all of the children who should be considered are being referred. And I think I don't necessarily have that sense of assurance at the moment. So I think we need that deep dive to be really clear. But then we need to understand that actually the offer is fair and equitable. And I think it's fair to say that there are different practices across Herefordshire and Worcestershire. So I think we need to really, really look at that and understand it. So what I've asked for is that we have a system-wide review of all things which relate to sort of children and health, so that we clearly link in with our partners in the local authority, with education. I can say that as far as children's continuing care is concerned, I've just started a proper panel process that's a panel process with education and social care to make sure, and that went brilliantly. We had our first one last week to make sure that, you know, we're all talking about the same children and families. So let's do it together, and let's actually document and record the actions so that we're not doing it in isolation. And then let's make sure we're getting the input into the EHCPs in the right way, so that actually we've got that sort of 360 holistic view and response. I think, to be fair, there's a lot of work to do, but I think we're just about to start that journey, really.
Possibly we could flag to see you in a year's time, or whenever it is that you might have done work. Thank you very much.
Yeah, do you have a timeline for the review?
So the review, it sits with the Children's Commissioner. So I've had one meeting with the Children's Commissioner. We think we're going to need to basically get somebody in external to help us do that, because we want to do it at pace. I'm afraid I'm not able to give you a timeline today.
If you could keep us updated.
Yes, absolutely.
Thank you.
Chair, if I could just formally welcome the news of the review that James announced, and make a general comment that the maturity of the relationship between the partners in terms of the authority in the NHS is more mature in the adults than it is in children. I think we recognise that. We're now discussing how the integrated care system will become part of the system in terms of treating equity between children and adults, because it hasn't been there to date. And also welcome that the authority is moving to an all-age position in many areas, and that the interaction with the NHS and the CCG, which will become, of course, the ICS in July, is moving into a very different position than it was. And I think that we've acknowledged and had a lot of discussion today around the spirit of collaboration and the depth of partnership that we now have. And I think that Jane's been very responsible for much of that growth in terms of partnership and cooperation, and it's very welcome. So I thank you for that.
Thank you.
Yeah, it does feel like it's tremendous progress being made there. So well done. Thank you. So we have the
Good time.
Sorry,
that's right. I did wiggle a finger, but it clearly wasn't a wiggle enough. So thank you for addressing our concerns. It is nice to have a report that comes back and addresses our concerns. And I think I agree, as I always do, with the chair, that yeah, I think it would be really useful to come back to this in a while when it's had a real chance to bed down, and actually where, of course, some of the year-on-year figures are directly comparable, rather than going, oh, well, but there are other factors. So I think that would be really good. Mandy looked at me with great anticipation in terms of the, has she got all the abbreviations? So it would be remiss of me if I didn't point out a little bit of proofreading. And, well, I'm not being completely flippant about this. In the introduction, it refers to us meeting in October, in August, I beg your pardon, 21. I think you'll find it was September. If it was August, I don't know what you got up to, but I missed it. And also in tables 3 and 4, those cluster groups, it may be deliberately obscured so that we can't read the x-axis to see which, but well, very difficult. Impossible. Thank you, Vice Chair. You know, it's always nice to have data that's actually readable, unless you're deliberately trying to obscure the facts, which I'm sure is not the case. Thank you, Chair.
Thank you, Councillor. So are members satisfied with recommendation to note the report, and if we can put in additional recommendation to be cited on the review and to come forward, and reserve the right to have another look at it at some point, you know, 12, 18 months, or maybe longer, when we feel that time's right.
12 months.
Yeah.
Discharge to assess what
discharge to assess. What's the recommendation there?
Well, we need to look at it. We're still working on it, so maybe it can come later date.
As a work program?
As a work program. Something.
Well, what we might do is just put that in the work program.
Yeah.
Okay.
Lovely.
And that means that we can put this to bed, as it were.
Yeah.
So that we have, so that we can
We're trying to get-
concentrate on discharge to assess it either in isolation or in conjunction with any other issues that are related.
Okay.
Because that is the biggest thing right now as far as central government is
Yeah,
concerned, I
it
believe,
is.
isn't it? So.
Chair, if I can just confirm for Councillor Summers that the council with its partners is working on a new model for discharge to assess as we speak. When that new model is finalised and there is a proposal, that of course will go through the governance process in order to be embedded, and of course part of that will be that of course scrutiny can look at that model.
Yeah, so the committee notes the updated briefing paper, and also that the committee will be cited on the plans that come forward and review continuing in the next 12 months.
Potentially, reserve the right to.
Okay.
Yeah. Okay, those in favour? Thank you. Thank you. Thank you very much. Okay, so agenda item number 11, we're a little bit behindhand, right? So we may overrun. This is the care and support charging policy, and so for this item we have officers Lee Davis, head of prevention support, Susie Binns, welfare and financial assistant team leader, who will be giving a short presentation as an introduction to this item. Over to you.
Okay, thank you very much. Hopefully you have the slides available to you.
Nearer your mic, Susie.
Sorry, I thought I pressed it.
No, just bring it nearer.
Bring it nearer. Is that better?
Yes.
I believe you do have a copy of the presentation. Here we go. Available to you. And I'll apologise in advance if the first slide actually, if we could move on to the first slide, please. Doesn't mention Department of Health and Social Care in full, it should have.
The report does, Susie.
Yes. Are we okay to move on to the first slide? Okay, thank you. So just as a brief introduction to this item, we've conducted a review of our care and support charging policy, mainly because the last time we reviewed it was in 2016, which is quite a few years ago, and we wanted to ensure that it was still fair, equitable and compliant with the Care Act regulations, because we renewed it in 2016, which is within the first year of the Care Act coming into being. And as the years go by, you get Care Act decisions, changes and various things come through. So we wanted to just make sure that everything was still equitable and fair. So we've conducted a review of our policy, and we had some areas that we needed to focus on as a result of council opinion around our policy. And these were mainly to ensure that when we look at people's income, the amount of income we're leaving them with after charging, that we do consider whether we should actually leave them with an additional percentage of income over and above the minimum income guarantee that the government suggests. And we've also been asked to review our current approach to leaving people with the minimum income guarantee. That current approach is that we use the government regulations, and the government regulations state the minimum income guarantee figure each year. So since 2016, we've been using those levels, but now we're looking at proposing to increase the levels to a higher amount. We've also been asked to look at how we treat individuals' incomes within our policy. And again, at the moment, we actually disregard some individuals' income when they're in receipt of high rate benefits. And I'll get onto that in more detail as I go through the presentation. But these were the areas that we were asked to specifically look at and ensure that our policy was fair and equitable. If you could move on to the next slide, please. Sorry, I'll do the same one here. So what we've done so far is we did some initial engagement with some of our local disability groups just to get a feel for areas where they felt our policy wasn't fair or equitable. And as a result of that, we then put together some proposals. There were 5 in total. And we wanted to look at it more detail in terms of making amendments to our policy. We ran a consultation from the 15th of December through to the 10th of February. And unfortunately, we didn't get as high as response as we would have liked. We had 61 individuals respond to the questionnaire, but we did actually contact every single service user that was in receipt of social care at the time. We did offer them access to a helpline so that they could actually ask us questions, and also an email address was provided for people to email in their questions. What we did find as a result of having the helpline, a lot of people were phoning us, and when they discovered that our proposals actually meant they'd be better off, they weren't inclined to actually go ahead and complete the survey. And five of those specifically did say that. We can't say for exact how many that would have been, because obviously the surveys are anonymous, but we did get a general feel that once people felt they were okay with things, they weren't going to actually complete the surveys. Those that did respond, 69% completed the survey online and 31% asked for paper versions, which we sent out in the post. 45 people were financial representatives and 21 were service users themselves. We did have 5 requests for easy read versions, and again in the early stages of the consultation we'd put together an easy read version with our comms team, but we did have representatives from Making It Real come up with some really good suggestions about making it better, so we did change the easy read version and that was sent out to those that requested one. We did have one face-to-face meeting with an organisation. Again, we put an offer out in our letters that any community groups that wanted us to come along and present to them our proposals, we were happy to do so. And there was one provider that did actually arrange that for us. And so we did meet with a small group there. And again, we've been involved with the Making It Real board in terms of going through the consultation process with them. Next slide, please. So going on to the proposals. Proposal number 1 is the most favourable of the proposals. And what we're basically aiming to do here is leave people with a minimum income guarantee after charging for services that is equal to the amount of pension credit or income support entitlement that that individual would be entitled to, with an additional 25% buffer on top of that, to give them a certain level of income to live on per week after charging. So this, as I said previously, is higher than the government minimum income guarantee that is currently set in the regulations. And when we asked people about this proposal, 57% felt they'd be better off, 34% mentioned they didn't think they'd have a change in their circumstance as a result, and 9% felt they'd be worse off. In actual fact, everybody will be better off as a result of this proposal. And I've just pulled out some of the key comments from that. People felt it was definitely a good idea. They're struggling to afford basics. And that obviously with escalating energy and food costs, there were concerns, and this additional minimum income guarantee would be helpful to them. We did have a comment about making it clear what the actual amount for the minimum income guarantee plus 25% would be, which we will be doing when we consult with people further if these proposals go through. At the time when we were actually doing this piece of work, the minimum income guarantees hadn't yet been announced at that point. We could go on to the next slide, please.
Susie, so can we just emphasise that point? So at the point that the paper was written and the end of the consultation, the government hadn't published the minimum income guarantees for 22-23. They have subsequently done so in the last few days. And Appendix 7 in your report gives you an indication of how we differ and in fact are above the minimum income guarantees that the government suggested. So just to be clear around that.
Chair, could I just seek clarification? In the paper, you're talking about recommendations. Here, you're talking about proposals, but it's the same thing.
It's the same thing, sorry, yes, it is, yeah. Here I'm talking about the proposals that we put forward as part of the consultation.
Yeah.
Yeah. Okay. So proposal number 2, again, we did have some feedback from families through the consultation that some people have younger adults that have left home with severe disabilities that need support through adult social care. And again, as the Department of Health and Social Care minimum income guarantee, they're left with around £19 less per week than a working age person of age 25 or more. And they ask, you know, that doesn't seem to be fair. You know, why should someone that's 5 years younger have less income? So again, what we're proposing here is that we actually give all working age people the same minimum income guarantee, regardless of age, so that this will give them some additional income left in their pockets as a result of this proposal. So again, the majority here obviously felt that was going to be fair, and it was only recognising that younger people don't have lower costs to live on. There was one comment about someone, you know, felt that their grandson could benefit from this in the future. That's proposal 2. Proposal 3, go to the next slide, please. Proposal 3 is one where we're actually removing an income incentive. Where people are in receipt of high rate disability benefits, they currently, those that are in receipt of either disability living allowance or attendance allowance, have an income disregard of £29.60 per week, which we disregard from their benefit entitlement on the basis that if adult social care is providing them with only services during the day, and those particular high rate benefits are paid for the recognition that they have nighttime care needs, we leave them with that element to help cover for any nighttime costs they have. Since 2015, you'll probably be aware that personal independence payment is one of the newer benefits for working age people. That benefit doesn't distinguish between day and nighttime care. So therefore, if you're in receipt of personal independence payment, you don't get an income disregard. What we're trying to do here is make sure that we're equitable to all people with high rate disability benefits. So we're planning to remove the disability living allowance income disregard, but replace it with an expense. So if anyone is paying for high rate nighttime costs, we will allow that as an expense in their financial assessment. But there will be some that actually receive that benefit because they have nighttime needs, but they don't actually pay for any nighttime care. So those individuals would end up with less income. However, when I get to the next slides, you'll see that by combining all these proposals, the overall impact on those individuals will be around £6 a week. We did, as part of this consultation, also ask people how many of them were paying for any private care. And again, the majority, as we expected, 68% weren't. So we do envisage that quite a few won't be actually paying for that. And as we go through the presentation, there will be a slide that covers that in more detail. Next slide, please. So this slide actually sums up the overall impact of proposals number 1, 2 and 3. So by giving people an extra minimum income guarantee, 1,130 people would actually on average get a reduction in their charges of £16.59 per week. By increasing the minimum income guarantee for the under 25s, 54 people would actually have an average reduction of £24.17 per week. But with removing the income disregard for those in receipt of disability living allowance and attendance allowance, 331 people could have an increased charge of £29.60 per week. But when we combine all of those 3 proposals against the individuals, it's 822 people will have a reduction in charges and 308 people would have an increase, and the average increase would be £6.03 per week. So overall, by restoring the minimum income guarantee to a higher level, but taking away the income disregards, the overall impact is lessened quite considerably. So we end up with, like I say, £6.03, the average increase. Next slide, please. This slide goes into a little bit more detail for you to show the highest and lowest. So for those people under pension age, the people that are impacted the most as a result of these there are 28 individuals that could have an increase of £23.13 per week, the highest being £28.25 and the lowest £22.31. For pension age people, 280 will have an average increase of £4.32, again the highest £9.14 and the lowest £2.73. And then I've given a little bit more detail here. So 205 people would get increased charges of less than £3. 75 would have charges between £7 and £9, and 28 would have over £20. And those people that are impacted the most, we plan to actually conduct a full review with those individuals. So that would be a full face-to-face review, going through all of their income and expenses to see whether that will actually be the final increase. There may be some disability-related expenses that we haven't taken into consideration before. So this is obviously also based on our current cohort of service users. Again, this is changing daily as people come on and off social care services. So this is a snapshot in time at the time when we put these proposals together. And any changes to individuals' expenses will also need to be factored in. So, for example, as you'll know, council tax has just gone up. Our means test includes any council tax and rent liability. So again, these figures are based on the here and now. But if council tax has gone up by £3 a week, for example, those 280 pension age people might not actually get an increase in their charges at all. I can't give you more detail specific on that at the moment. You'll be aware every parish has its own parish addition to the council tax. So we're not able to give you a more detailed figure than that at this moment in time. Next slide, please. So proposal 4 is separate to the previous 3 that we've talked about. And this is again an area within the statutory guidance where if somebody goes into a care home, there are separate rules for how we calculate their charges, and those rules are set by government. We can't dictate how we charge for people in care homes. But where someone has a short stay in a care home, the government does give us discretion. So we can actually look at making a different process for that charging. So what we're proposing here, recommending, is that for people that have short stays for up to 8 weeks in a care home, we would calculate their charges under the same rules that we charge for them when they're in their own home, rather than charging under residential rules. This again is to their benefit. If you go into a care home, all you're left with is a personal expense allowance of £24.90 a week to live on. So by doing this, we'll be much fairer because we'll be leaving those individuals with the same minimum income guarantee that I've mentioned previously when they're living at home. So we are proposing that we implement this. It's also much simpler for us. It's very difficult when people sometimes will go into some respite for just a couple of days during the week. The remainder of the week, they could be having home care at home. So we're doing one calculation for part of the week, another calculation for the rest. It gets very confusing for people and it's not easy to administer or explain. So I think this will be a very good proposal to put forward and much simpler for everyone all round. Next slide, please. So overall, just to summarise the financial impact of these proposals or recommendations, by increasing the minimum income guarantee, that will cost the Directorate £975,000. by giving the same minimum income guarantee to all working age people. That would cost an additional £68,000. Removing the income disregard will save £510,000, and applying short stays under different rules will cost £63,000 additional. The overall cost to the Directorate is £596,000, which has been included in the budget already set for this next financial year.
Susie, can I just pause you there momentarily, because Councillor Gandy will have to leave. We are clearly going to overrun, so I'm just going to let the committee know that the work programme agenda that will leave the agenda, so this will be the last thing that will be scrutinising today. But because Councillor Gandy has to go.
Now, I'm ever sorry, I've got a parish council meeting on the Welsh border at 7 o'clock, so I will need to go. I don't have any problem with the majority of these recommendations. I am obviously concerned about the possibility of some people having to pay possibly as much as £100 a month increase if they have their interview and they aren't, and I know there's not many of them, but if they have their interview and it's found that they don't actually qualify. This is always a problem, and I recognise it's always a problem. And you could argue that it's a problem because we've not, over the years, we haven't adjusted the payments. But for people on relatively low incomes, I'm not talking about the very wealthy, but on relatively low incomes, human nature is that they tend to live up to their income. I mean, you know, some people as they get older and, you know, they have less, they don't perhaps have a mortgage, or they don't perhaps have to pay off buying a car or whatever. They do have the opportunity to deal with the extra costs. But particularly at this moment in time, bearing in mind what's happening in the real world for all of us, I am concerned that for a small number of people, a significant increase that they haven't perhaps expected to come, when they're probably already living up to the income that they're getting, will cause a problem. And so I'm sure it's probably not as many as the 28. When you've interviewed them, you'll probably find that there'll be less. But even if there's only 5, for those 5, that could be quite an issue, because I think all of us, you know, we're looking at what energy costs are going to be and food costs are going to be. And so I would be interested to know how we might tackle those 5 or whatever it might be that are going to be faced with quite hefty increases in their charges.
Yeah, so they can actually appeal. So if once we've done the review, it still turns out that they still have quite a high charge, they can appeal against the charge, and we can look at that on the grounds of financial hardship. So we can look to see whether, if there is going to be financial hardship, can we reduce that charge as a waiver for a period of time to help them?
Because perhaps stagger it. So.
Yeah, but what we also do generally when someone's suffering financial hardship, we look at the overall picture. They could have high loans, they could be paying really high building insurance, all sorts of things. We could actually perhaps reduce some of their other costs to help them then pay their contribution towards social care. So with an appeal, we would look at a full income and outgoings and to see if we can help them that way as well.
Right, thank you very much. That's very helpful. Thank you.
Susie, do you need to return to the presentation?
I think we're just on the final summary slide, please. And the next one, please. Thank you. Yeah, so in summary, proposals will cost £596,000, putting that money back in the pockets of our service users. If they do go ahead and are recommended, then we expect 73% of people, 822 as already mentioned, will have the reduction. 90 of those will no longer have to pay for any care, and 308 may have that increase. And as I've already mentioned, the average increase is £6.73. And again, reiterating that those of working age that are affected the most, we would conduct the full review on. We do aim to implement these changes from the 11th of April. The main reason being for that is that this is the week when all the benefits change. Everyone would get their inflationary increase to their benefits. council tax will be known by then, rent increases will be known. So we would like to try and implement these changes at the same time as all these other changes. If they were to be delayed, it would mean having to write to people again, and can be quite confusing because we bill every 4 weeks in arrears for services. So you could find us, you know, you send a letter 1 minute and then a couple of weeks later they get another letter and then they get a bill, so they'd be confused which is the right figure, etc. So we would like to try and implement these changes from the 11th of April. It is going to be very tight because of the timings of the governance processes, but we feel we can, if that decision is made by Cabinet, that we can meet that timeline. Thank you.
Thank you very much.
Thank you, Susan. Really helpful presentation. Really complicated bit of work.
It is.
But it's been done incredibly well, and there's a lot of detail around it. The important thing, I guess, is that a lot of effort was made around the consultation, and it's disappointing that we've had a very low turnout. We did write to every single person that we have within the system. In addition, councillors will know that this is going to Cabinet on the 24th of March. In the previous review, this was deemed to be a Cabinet member decision, but in consultation with the Cabinet member, and I fully support this, we believe it to be such an important decision that it should be elevated to a Cabinet decision. Within the Constitution, this is actually a delegated decision, but we believe it to be too important for that. And we've agreed that with the Cabinet member that she's comfortable for this to go to Cabinet.
Thank you for that clarification. It is a complicated piece of work, and thank you for the report and the detail that's in the report. And actually, although the consultation might not have had a lot of responses, actually, I very much appreciated the depth of the consultation. You could see it, so that's very good. So right, over to the committee. Anyone got anything they want to say? Councillor Marsh.
Hijack Councillor Gandy's microphone. Or her husband, yeah, well, the entire Gandy family's microphone. That's right. Yes, like Councillor Gandy, I can see that we are likely to hear disproportionately from the 28 people who will first get their bill at the end of May. And I am very glad that overall we're putting money in and that most people will benefit, but I hope we will be able to perhaps offer to do the face-to-face before they have to pay. And as you say, they may well have all kinds of ridiculous insurances that maybe could be improved, and I hope that will be the case. They're mostly, I assume, people who are on some form of disability benefit and are not well off. Am I right, that haven't got a capital reserve? So these are people. Yes, so I just think we do need to be especially careful about that.
Yeah, yeah.
And one other thing was that in the answers to the consultation, there appeared to be a few perverse outcomes, like there was a couple who felt that they'd tried to cut their care package back, but it was just as expensive. And then there was the lady who said she'd have to give up work because she was going to lose all her work. And again, that seemed like something that if we, because she'd be earning too much and then it would all be taken off her. Yeah. So I don't know if there is anything we can do for these unusual cases, but Susie, I'm so grateful for your attention to detail honed by decades on, is it council tax or business rates or whatever it was that enables you to keep a feast of figures in your head.
Yeah.
And also I was a little bit confused that it said we spent 29.1 million, but we were only getting 4.1 million back, although 78% of people were contributing. And I was going, well,
that's right.
That seems a ropey deal.
Yeah,
is that right?
That's right. So the 29 million is what we actually pay out to care providers to deliver the care. The 4 million is what we actually receive back in income when we carry out these means tests on individuals. Their contribution often isn't anywhere near what we're paying the providers for the care. But the 78% is where that's the number of people that are contributing towards care, but the amount they contribute is not as much as what we're contributing.
So actually I realise there are two questions. One is the feelings about the 28 and the other is our comms to say clearly that many people are benefiting from a fantastic package already, where we spend 29 and we get 4.1.
Yes.
Left sounds like a bargain, and that we are making changes that will benefit many people. And sorry, there's just one more point which I can't read because my left my specs in the other place. Oh yes, just about the our admin costs, because maybe let's do it for another time, but increasingly as self-funders look to us to perform tasks on their behalf, I would very much welcome a understanding of how it is that we charge them and how we encourage them to come through us and that, but not today.
Yes, yeah. Just on that, we can only recharge what it actually costs us, and the figures are based on our calculations of how many hours you spend actually administering.
Oh, so you can charge.
We do charge self-funders an admin fee, and it's
on an hour by hour.
Yeah, and there's a one-off fee for our brokerage for that as well. So we charge per invoice, and there's an admin fee as well for that.
As a general comment, Councillor, of course, as the Adult Social Care Reform Act becomes a reality, there is a working group that's been formed now to how we begin to gravitate towards that new legislation. And of course, our approach to self-funders will be part of the Adult Social Care Reform. So that will come forward at a future meeting there.
Thank you.
Thank you. Yeah, I mean, broadly, yes, you know, you can see this makes sense. It benefits most people. There will be that cohort where, but early engagement, communication is vital there. So apart from that, do we need to be concerned about inflationary pressures, which are kind of costed in as an assumed rate, and I have a feeling that the rate is going to be somewhat different, and indeed the speed at which things are moving with that, particularly with fuel. That in a sense, the decision taken today might be completely different tomorrow. It's very difficult, isn't it? So have we got a designed-in safety net, as it were, for things, but particularly fuel costs, which are spiking very dramatically at the moment?
Yeah, so with regard to fuel costs, particularly around heating one's home, the way our means test works is that it's only excessive fuel costs that we will allow as a disability-related expense, because the minimum income guarantee people are left with is supposed to cover their day-to-day living expenses, and that's gone up by the 3.1%, which obviously heating bills have gone up by a lot more. So where people have excessive costs over and above the average, we will be increasing their disability-related expenses in line with their increased costs. And we will be, when we write to people, we will be explaining how that works, because we're already getting a lot of people contacting us now, asking can they have their charges reduced because their fuel bills have gone up. But it is about excessive usage because of your disability, because everyone's charges have gone up. So that is a difficult message to get across. And obviously we have the government intervention around that with the £150 of the council tax and the £200 of the bills. So that is addressing it in part. So our means test at the moment is based on the minimum income guarantee set within benefits. If the Department for Work and Pensions happen to increase those benefits mid-year, then obviously we would increase our minimum income guarantee in line with that.
So effectively, because as I said, the minimum income guarantees have been published now, and we are above those government guidelines. But effectively, the approach is that the general approach to the cost of the increase in cost in fuel applies to everybody, and of course that you and I as well as everybody else. But we recognise that people with disabilities have a higher than usual demand in many instances, so we compensate and take that into consideration. But we don't and couldn't really try to resolve the general population issue that the fuel costs are rising. So we recognise and compensate for higher usage, but of course we can't compensate individuals for higher cost bases, because that would apply to the whole population. So that's the way that this works.
Councillor Summers.
I'm a little bit stupid on this stuff, so don't mind me asking dumb questions, but everything seems to rotate around benefits. If you're on benefits and et cetera. I'm very concerned about the working poor that could be on benefits, barring their stubbornness to push through. What do we do for them is my question, I guess. Thank you.
So yes, it is a means test, so it is based on your income. So if you do have income above the minimum benefits, then we will be taking a percentage of that income back from you in charges. What I can say is for those that are of pension age, that are in receipt of pension benefits, if they get a savings pension credit, if they get a savings element for that, we do actually disregard all of that in our calculations. So I think it's about 200 people that actually get a savings credit. It's around £10 a week. Again, it's average because it's based on income, but we will be disregarding income for some of those people.
Thank you.
Thank you, Chair. I'll preface it with a remark so that Paul and Mandy don't feel that they're being just picked on themselves. There are some shocking statistics use of in this report. 73% will see a decrease, 8% of which, does that mean 8% of 73% or 8% of the 73, in which case it's 65 and 8, as opposed to 8% of 73. And then the following, section 13, where 24% of 22%. Dear God, I am glad I'm not marking your homework. It would really be helpful, to talk about numbers of people rather than 24% of 22%. And but I've made my point. And also the use, not the use, but throughout the report, I was getting very confused about how many people were going to be affected, by how much, because we had different amounts and different numbers of people, and sometimes it was up to, and so. And whilst I am not a great fan, to put it mildly, of a presentation to any meeting which goes over much of what we've already got, in this instance, actually, it was much more helpful because we had some final figures. So that was very helpful. And obviously, like colleagues, my concern is with those people who will be paying more. And the chair very usefully raised the issue, one of the two questions that I was going to raise about increased bills, particularly with regard to fuel. My second question really is, I'm just a bit concerned about the timescale of all of this, in particular, these letters that are going out to explain the changes. I was alarmed when I read the report, thinking, well, if it's from the 11th of April, that's a month away. I'm slightly even more alarmed now that it's going to Cabinet first, which pushes it on, another fortnight. Really, if the letters don't go out until after the 24th of March, even though they will be letters to many people saying you're actually going to be better off, I'm just, people are going to barely have 2 weeks' notice of these changes. And I'm just concerned about the anxiety and uncertainty and worry that's going to arise because they've had the consultation. You can see that even when it's a benefit, but they're going to see an increase, people's natural negativity, if you like, no, I'm going to be worse off. And I'm just very worried about the timetable that this is happening to.
So yes, I think, yes, it is very tight. We do write to people every April. They are aware, those that have had service for some time are aware that this is something that we usually do. We usually notify them in advance. We don't actually bill people until the end of end of May. So they do get a period of time before they actually get the bills on the doormats. And what we do find is in previous years, when obviously the charges have gone up, we find actually it isn't until the bill arrives on the doormat that they actually contact us with concerns they do get their letters and their statements, but it's usually when the bill hits the mat that they do raise the concerns. But obviously we are going to try and make sure with this, because there are changes going ahead, that we include much more information about what the changes are, what they will mean for individuals, and offer them the chance to ask for review, and obviously contact our helpline as well. So we are going to do as much as we can with our communications to make sure people can.
That was sort of my supplement. So the letters will be personalised. You will be this much better, worse off, or, you know, so actually, even if they don't complain until the end of May when the bill arrives, you can legitimately say, well, you were told in April that that's what the bill will be. Okay. Okay. It's still very tight, as you say. But...
Councillor
I'm just a technical question, that you're above the government minimum guarantee, but have you promised to be a certain degree above it? Because then if the government put it up, we'll be stuck. You haven't.
No,
that's all right. I'm just thinking that would be a hostage to fortune. I would be glad for us to avoid. Good.
The government put in the middle, which is a fairly unlikely scenario, I believe.
Yes. Just in case. Thank you. And yes, I too am very relieved to hear that the letters will be personalised and that there will be some time for people to get in touch, even if they don't until May.
One thing that struck me reading, particularly the consultation responses, some of, you know, a lot of it was sort of, you know, yes, no, but one or two of them were very thought out and had some interesting insights, I thought, some very worthwhile insights, not specifically relating to this, but, you know, certainly giving me insight over, you know, and I would wonder if maybe we should have a recommendation around capturing those fuller explanations within the consultation and reflecting upon them. Is this something that we maybe, you know, we can take away and learn from, in terms of, there are a couple of instances that I took out. One was a full-time carer for his wife, and that their experience was that there was no incentive to be more independent, and the system was set up to disincentivize the very thing that we would seek to be supporting. So I think I would be really interested to know, do we, you know, can we kind of capture and reflect on that? Yeah, it's just not but just as a general thing. There also was a comment about there were two other things that struck me as being worth capturing. One was well, the comments about secrecy about what can be disregarded as disability related expenditure, and I thought that's actually, because actually, you know, people are to make decisions, they need to make informed decisions, and we need to make sure that they are empowered to make those informed decisions. So that would be something that I would like to see us capturing. Yeah, okay. Yeah. And the other point was, there was one about the disadvantages of home ownership over rental, in terms of what you can and cannot offset, because a home owner has to be responsible for, you know, if their windows are leaking or whatever, you know, but they can't claim for any of that, whereas a rental property, your landlord will take care of it. So there's an inequality in that. And I thought that was an interesting comment as well.
Yeah, so certainly the one of those three that we picked up on that we feel we can do something straight away with is the question around secrecy for disability related expenses. We do recognise that perhaps we haven't given as much information as we could have around that. So we've already updated our web pages, and we are going to be again including more information now with our invites for financial assessments, to tell people up front what we consider to be disability related expenses. And it isn't that we've been hiding them, it's just that we ask people, have you got any? And we, you know, how are they to know what they are really? So we need to do more about explaining the sort of things that they could claim for. So we have taken that on board.
Yeah, I very much. I don't see this as being a negative. I mean, I see it being, when we've gone to the trouble to have a consultation, and people have gone to the trouble of actually responding, that this is something that we can we can learn from and we can benefit from. So that's my thinking, Lee.
And if I,
sorry,
if I may, Chair, we've also accepted an offer to work with the Making It Real board to develop and improve the guidance and to make that much more accessible than it is at the moment. And that goes, I think, also to your point.
Yeah, Make It Real board.
Because there's I mean, another one of the running themes in the response is being able to understand it. Quite honestly, you know, you know, I won't go on about jargon or abbreviations. I've done quite enough of that. But yeah, making it much plainer English.
What I wanted to add to, Chair and councillors, is the Making It Real board is becoming much more of a force for co-production within the council. So that's emerging now.
Good.
And as part of this exercise, the Making It Real board offered not only individual responses, but a consensus of this would be better for people with disabilities. That was taken on board by Lee and Susie, and we rewrote some of the consultation in line with their recommendations. And I believe that now, in terms of our approach to co-design and co-production, that the Making It Real board will be a visible force in all of the engagement that we make in these sort of areas, and it gives them a voice. And they are absolutely, they're even embedded now within the integrated care system as a recognised group, which is an excellent step forward.
Yeah, good. That's very good. So any member of the committee got any further comments? No, thank you. I think we've lost Christine. So suggested recommendations.
The proposed changes to the care and support policy, possible communications, that mentioned, highlighting the blankets or perhaps positive thing within.
I think, yeah, I was sort of timing of engagements and things, really. Is that a recommendation? Do you want to make that into a recommendation?
Given.
I think we could make a recommendation around capturing some of the comments in the consultation feedback and using that as a learning tool.
I'm not sure. I'm still consider the working poor. I was just wondering if we can put working poor in there somewhere. I don't know how it would work, but everybody seems to forget the working poor, and there are a lot of them out there, and they're on the edge all the time. They work because they're too stubborn to use the system, and I think somehow we need to bring them into. I don't know how.
Agree, councillor. And of course, we do want people to work if they're able to do so. It's part of our strengths-based and independent care. So what we could do, Chair, if we could take a recommendation away, perhaps to come back with 2 or 3 scenarios for the group, so that the committee can see that in scenario 1, 2, and 3, working age population, somebody is working and is working poor, how this would have impact on them as an individuals.
I think so.
Just to clarify, working people with disabilities, we disregard all of their earnings. So sorry, when I was referring earlier to people who'd worked all their lives as a pensioner, and then we disregard their savings credit. People that get adult social care services have all of their earnings disregarded, but we have a very small number of adult social care service users who work.
But there's still those that are actually working poor. That don't get any benefit. And those are the ones I'm concerned about. And it seems that across the world, those people don't count sometimes, and I think we need to let them know they do. Anyway, it's just
there was an overall issue with visibility of people not in the system, and you're quite right. You're quite right to raise that.
I'm kind of assuming that if you did a financial review with someone and it was clear that they could claim a benefit, you would at least draw this to their attention.
Of course.
That is part of our financial assessment. We make sure that individuals claim all their benefits they're entitled to. Yeah.
I'm good.
Okay, thank you.
The thing about possibly coming back to self-funders, is that a different issue, or we could? It's all right. It's fine. But
no, you're right to raise it. I mean, I think that is another conversation around self-funders and the relationship we have to them. But I think probably it requires a bit more space and time than we've got right now.
Sure. No, I think I just wonder whether it should be a recommendation that at a future time the committee may would like to look at how we facilitate effective work with sub-funders for mutual, whatever it is, benefit or something along those lines.
If I may, Chair, I think we should treat that as a separate item.
Yes,
because how we deal and approach and support self-funders now will be very different if the Adult Social Care Reform Act becomes legislation.
Yeah.
So we should perhaps revisit that.
So yeah, but this is an evolving picture.
Yes.
So it may be that can we have as a recommendation that we have a briefing or workshopping session that is looking at this evolution? Is that possible?
That'd be really helpful. Yeah, absolutely.
Great, let's do that then. So, yeah, recommendation that we have a workshop to look at the evolution of relationships between the council and self-funders. Okay.
Yeah.
Do you want to go over them?
We'll go on. The briefing workshop be held to look at the evolution of the relationships between the council and self-funders.
Yep.
The authors of the proposals to come back with multiple scenarios and how they would impact on individuals. Future reports published on this subject avoid potentially ambiguous use of percentages where possible.
Could you put that as a recommendation?
If I could just say that actually the cabinet member for wellbeing already identified that. we did try and get an amended paper through, but unfortunately that we missed the boat, so to speak. So when it goes to cabinet briefing, all the numbers will be in there, not the percentages.
Good. That's now got a low voice in the world.
Focus on capturing the feedback on the consultation with a view to providing greater transparency about perceived secrecy surrounding disabilities, enabling people to make fully informed decisions.
Okay. So I'm happy to propose all of those recommendations. Councillor Summers will second. Councillor Bartlett, do you wish to make any comments at this point?
Thank you, Chair. Really good debate. Good to hear that those amended figures will be, numbers will be in the next report. Just to say, this is a lot of this is really good, and thank you to the committee for picking out the fact that we have got some people that will be affected, and we must make sure that we do everything possible on that front. And yeah, thank you for the opportunity to sum that up. Thank you.
Thank you very much, Councillor Bartlett. So sorry to have we're a bit late. 6 o'clock. Thank you. So that's that. So as I said, we're going to not move on with the work programme review at this point, but I think we'll take a separate session on that. If everyone's happy with that, yeah. Well, we could do an online meeting, but yeah. So we'll do a separate session because I think we do need to kind of properly do through it, because we've got 1 or 2 things that we can't today, and we may want to decide where they want to go. So if we can arrange for, we'll have an online briefing or some other meeting to discuss the work programme. Dates for the next meeting yet to be confirmed, likely to be in May. And the last session of this municipal year. I'm now going to formally close this meeting. You can the live stream.